people ask about fine lines, and I will tell you that the lower face is an area that's very commonly overtreated to ameliorate the telolabial folds, and which is the labial exterior fold, which is a common area of problem. That descends inferiorly with gravity and toward the midline with muscle action, and it's the same with the nasolabial fold. But if you treat it like you do a nasolabial fold where you're bulking it up, you can really bulk up the chin, and in a woman, a giant chin is a very masculinizing effect. So by doing a fine line treatment, just like we used to do the old collagen product, which is not where you're truly doing an intradermal injection, not subdermal and blowing up like a balloon trying to make the whole thing bigger so that it doesn't have any lines. But with cervical injections that are placed truly intradermally, you can get the same result. The challenge is that people get tendon effects, which is where you get this cervical issue, and very commonly you'll see a little bridge in the line where you put these very big HAs and fine lines, which is really not designed for. So that's part of the so-called gains, which is really just dilution, and we use the level of dilution about none of them to show tendon effect for 10 milligrams per milliliter or less. So we've got studies that published that if you remember that 10 milligrams per mil or less, you can take whatever product you want and usually lidocaine, we use lidocaine actually because it reduces bruising and do these fine line treatments, including very bad lines, the labial fold, and you can really get nice effacement of lines without pumping the lip up and making it look like a monkey, that we call a monkey lip where it sticks way out, or getting a huge jaw effect that was Renee's elevator cover of magazine had a huge chin. The whole article was written in this article about her lack of transition to motherhood, and the only thing people were talking about was what happened to her face, because her jaw was so huge, which was the main problem. She also had proptosis from Botox, but that was sad. Her faces became the subject of discussions about looking at things that had done for cosmetic improvements. These are also adjuncts to facelifting. This 57-year-old patient who is a TV personality. I won't say more than that, but she, if I did have, in this case, I used autologous fat and filler for her. She continues to get botulinum toxin and continues to do fillers to maintain these things. And same with this lady's got the deep rings under her eyes, and still a little bit. This was a lower facelift, obviously. So they become parts of your, the strategy. This is one of my, one of the big cases we do where you do a face, eyelids, and a nose job, and get fat transfer, and do certain things on there for 14 hours that day. But they come out with nice results. Almost all of 95% of my patients are getting filler because they're on fat when they do the few cases. So I've shown that already. And mid-face volume is another area because it's really, initially I understand the rationale of making a line, using Hinderer's lines as a guide for how you do it because no one really had any standard approach to the mid-face. But most people, when they lose volume, are losing it under their eye here in the V-shaped kind of appearance. That's often called a negative mid-face sector. And that's really where most people need volume. They don't need it out here. There's like an structure. A lot of people ask for it. If they still have that deep hollow, they still are going to get tired. So this is the area we should get used to treating. It's really an extension of what's often called the teardrop depression. And you want fillers in this area that are not hydrophilic because they can't look puffy or make it puffy for a safety is a big issue with these HA fillers, and there was a meeting that the FDA conducted about a year and a half ago, less than a year ago, and they really wanted to know about especially vision loss, because there are fewer cases in the U.S., not very many in the U.S., but counted to publish literature of vision loss. About the time we took this FDA trial, there were 157 cases. There were only 2 cases of bilateral loss of vision, and it wasn't total blindness in either of those patients, but it was light perception loss, for blindness. And those were mostly Asian. Almost all of the cases were Asian. And it turns out they do a lot of, I didn't know this, my fellow 2 years ago was from China, and they want perfectly round forehead. They do not want from a Boston. And so a lot of women get their forehead treated, and that's probably why those vessels, supratrochlear, supraorbital veins, and arteries are, straight line shots right down to the orbit. And if you were to get those, I think there's not many cases for treating below the eye. I couldn't find any origin. All of them were treated above. And it wasn't limited to HAs. There were some fat transfer also. So it wasn't limited to needles. There were some cases of blindness with cannula also. So for anybody that thinks you're safer with the cannula, I'll tell you that that's not the case in that small. Remember, the end is so big. Hundreds of billions now per year, probably worldwide. And the end of vision loss is reported it's probably much higher, but it's still less than 200. So it's rare, but it's something you need to be aware of. And much more commonly, you see what you see on the screen here. Someone that's got an occlusive terminal vessel, probably not my patient, but these are case reports that are in the literature. And this patient, and I think one of our members actually used a lot of treatment this patient. But they did resolve with some minor scarring, but I've seen azalea with necrosis, skin around the lips, or with necrosis. And I would just caution everyone with doing these things that you really need to be aware of what you're doing and watch very carefully the tissue around it and looking for any blanching that occurs and when you're depressing the function. I use an antegrade technique. That's the only way to do it. But in my mind, at least, as I advance the needle, I feel like the HA is coming out in front of it, or whatever the floor is, radius or whatever. And it's not, I'm not retrograde injection where it might be through a vessel. That may be my imagination. But I have seen it where I've injected, probably some of you have, started injecting with a cell retire, and you let it blanch, and you stop injecting, it stops it, it's fine. But if you're not really watching, you might inject it like a plug into a vessel, it's a vessel or something. And that's a nightmare. So we know now that flooding that with polyol days is the treatment, whether it's the orbit, and if someone's losing position, you don't need to worry that much about the eye. You need to worry about it. If you call an ophthalmologist, you get a lot of HA. And there's some chance, Julie Woodward did some studies that show that the HA does penetrate the vessel wall. You don't have to cannulate the vessel wall to have an effective reduction of these blood flows causing people with that vision loss. So colleagues have had that challenge. The other one, and there's a rise in these worldwide, these are very commonly used, the sort of permanent, sort of the actual permanent fillers. And there is a medical grade of silicone that's used for ophthalmology use and organs, artificial globes, but so they have that FDA clearance. It's technically not legal use, so it's not legal. There's also EMMA, which is approved, and it's approved for active scars. People are using lots of it, doing it with lips. I'm still hearing from other patients that have chronic vision loss. So the downside risk in my mind is you can't really see or feel the patient when you're looking at it. Her lips feel like rock hard, and so she comes in regularly for steroid injections. And I got to do. And this is a smaller And eventually we just had to take all the skin off and that was a big open nose. Super soft tissue for our nose. So I just caution you about using especially permanent fillers. It knows the full discussion all by itself. It's highly vascular. I just every day was doing an injection on a biopsy, and I always try to do a little needle, like do a draw and check and see if I'm in the vessel. Sure enough, I got a very good flush back with that. So, and one not issue, one of my members and colleagues got a great video of it. Of course, I didn't have a video because I didn't anticipate it to do it, but I would tell you that it's important to make sure you're not intravascular with it. So that lady I told you about, she first got a skin graft and before that flat. So we're going to talk about the Lux today, which is the newest of the approved fillers. This is from it's an HA filler with 25 milligrams per milliliter, so it will be in the higher concentration range. It's the higher concentration range. And there was a study that looked at the jawline and chin area. It's got very powerful lifting properties. So for people that have water looks like a deep, I would say a deep anterior notch down here, maybe a fold that's hanging well below the jawline. There may be better treatments for that, but you can do these things to soften the appearance of that aging change, or maybe just a deep chin with fillers. I prefer to the chin personally, but I certainly offer patients fillers if they go somewhere else to see the experience of it and see what they look like. This is a nice stiff one that's not going to move around under pressure, so it has a great appearance. I put this drawing up there because this is the one area we're treating along the jawline. Very, very prominent dermatology friend of mine has had 2 cases with the doses treating the jawline. And if you hit that right at the anterior notch, the facial artery, or extraocular artery, is really locked in place. And so if you're pushing needle into that, it's not going to move out of the way. It can't. It's sort of locked with a fibrous band at the end of your border. And so you're at greater risk of puncturing that, putting hemorrhoids in. It's obviously going to cause problems for every distributed small vessel. In the case of colleagues, it's both cases where it could go up with two. So I would say that while the popular expression of doing this is to stay on the bone, I think it's safer to stay off of the bone. If you really think of it and watch it as you're injecting people, you can't know what people. Just off the bone. Just be aware of how patients you can feel in your anterior pulse. So you can mark that and make sure that you're staying away from the vessel there and certainly away from the bone and hang down. So that's the little feature and then we'll do the treatment and Dr. Brown study we'll talk about some of the safety. So I tried to cover what I could. I think I mentioned most of the products that are out there. We certainly, everyone has their own personal preferences on these things. And I have my own which I'm happy to talk to anyone about. But I like all the products. The duration, I guess I have to look at it. I really, for patients, you do enough of this, you're going to see a patient that makes a great one. My feeling is that they're biofilm to do enough that they're actually, in fact, these are not type 4 guys, so it's really responsive. And every patient that I've seen has had one, whether they were symptom as referral or that I got it myself, responded to broad spectrum antibiotics, which is not just cycle for the long term, and then some cephalosporins, another product to cover some of the other things, not to cover virtually everything, it's not strong enough. And, but I'll give it to you for 6 months and it does resolve. And resist the temptation to inject them with hyaluronate because if they're contaminated, a biofilm will evolve the interface between the interface between the implants and the tissue to change some organs because there's not disease removed, there's no capsule around HA. You're not going to see a biofilm like you would around the breast implant or chin implant, but they can have contamination issues. And I've seen a couple of patients that do the point with steroids, hyaluronate, who don't have it isolated they may impact the spirit or something. If they're used wrong, painful, or show any signs to give you information. I would avoid steroids and use the antibiotics initially. Once they're on antibiotics, they're not being treated. So if there's any questions about the apprehension, we're going to be setting up with our live demos for the channel. And we're going to start with the neuromodulators.
Dr. Moraz back there, and Dr. Moss, when we're ready. So we kind of mix things up a little bit. First of all, any major questions? Or minor? But I mean, I think it's exciting that, I remember the first meeting where we, first had, the Juvo being presented, and then, the Luma, and it's like every year there's something. This year, we have two new things, we have Bolux, which Dr. Moss mentioned, we have a wonderful demo with that, and then, of course, the daxibotulinumtoxin. Who here in the audience has used the daxibotulinumtoxin yet? So it has been kind of slow rollout, and but we have the product here, so we'll kind of, show you, and we'll go on label with dosing, and I'm just, I'm going to start a little bit of controversy here with Dr. Sykin and with Dr. Moss, but every single neuromodulator, has a statement on it that units of toxin are not interchangeable among the manufacturers, because the way the number of units are determined are by an LD50, and each company has their own specific assay. So I think it's important that when we talk about things, and we just say, well, double the dose, I mean, we can kind of get into the nitty-gritty, but it's just important to understand when you talk to your patients that they cannot assume that 1 unit of this is the same as 1 unit of that. Now, what does that mean clinically? I think, as Dr. Moss mentioned, it's going to kind of play out when it gets into our hands and we start comparing things. And then, of course, the high-dose data, which, is published that Dr. Moss, kind of led the way on, is very interesting. So it's just a matter of what companies can say on label. As he said, Revance, their standard dose is 40 units in the glabella, and that's what we're going to show today. And we'll go from there. So, and of course, all these, we're not going to get too much into the pricing and that sort of thing because we don't really know what the final prices are going to be. But you'll see the Daxi for the first time, I think, okay, which is great, and the Volvo's as well. And I'm going to have Dr. Goldberg up here.
A lot of you disagree with something.
Good.
We like controversy in conversations. So, Corey, I'm going to flatly disagree with something that you said. We have a filler complication hotline standard. We've actually developed a filler complication standard called vision loss and granuloma necrosis. The only reason I mention that is because we see a lot of these. And if there is a biofilm, I think the first thing you want to do is break that up. Biofilm with silicone implant or something is that you have to take the implant out eventually. And the nice thing about the hyaluronic acid fillers is you can take them out within a day. I haven't had any of these cases of spread, and I would argue that even if it spreads early, these organisms in general are very low in variant organisms, that most people should be able to fight out, even if it's true, these spread will be around. I think they're growing there mostly because of foreign body and biofilm. I don't have to prove it, but anyway, my practice is to dissolve them immediately the day they show up and start antibiotics. I don't personally see a clear rationale to treat with antibiotics when they. Because the last thing I'll say is, don't forget, treatment with antibiotics doesn't work very well until the filter's gone. But it's there because of the physiology of the body.
That's very interesting because we had some interesting discussions yesterday about the immune response and whether something's inflammatory versus infectious and the clinical signs that you see. And we're going to be diving deeper into this and have a whole panel on this. That you're correct. However, if you do have something that is inflammatory and you're coming in and you're dissolving it, you're also exposing more of the product to the immune system and you might get a little bit of a feed effect, right? So I don't know. It just depends on the case.
In my patients, where I see them right away,
the camera up so we can have the audience. Again, we're going to project everything, so let's go to the right input. And we have Dr. Rath.
Testing, testing.
Should be out 2 right now.
Yes, she's on too.
Can you hear me? Yes? Can you hear me? Okay, it's pretty close. Can you hear me now? Okay, great. We're on. So first time is Disport. We have a 38-year? 39. 39. Oh, she looks so young. Okay.
We'll hold it for you.
39-year young model here who's had neuromodulators in the past. Her last treatment was a couple months ago. It's not completely worn off, but the concerns today are, go ahead and lift your brows up a little bit. There's a little bit of forehead movement. She's got, nice arch to the brow. Obviously a beautiful young woman. Go ahead and smile for me. Just starting to come back on the orbicularis oculi area, a little more inferiorly than superiorly, but we want to kind of keep things balanced, keep her brow elevated. Go ahead and make that bunny line. So this is primary thing, the bunny lines, and some of my patients call this the witchy lines, but I like the bunny lines a little more. But we can put about 10 units in the nasalis per side and knock that down. And go ahead and make an angry face for me. So just corrugator activity starting to come back a little in the head of the corrugator, and I'd like to put a little in the tail of the corrugator as well. So I'll have all this. Okay, we'll get her prepped. I don't get quite as OCD with my preps with neurotoxins as I do with fillers, but I still tend to prep and re-prep at least once. So I have alcohol and hypochlorous acid. I like that kind of on all my patients. Doing okay? A little bit of.
Can you tell us what the reconstitution volume is for the vial at this point?
Yes.
So the audience understands that you're a higher concentration or lower
Yeah.
concentration.
So the package insert approval is for 1.5 or 2 ml. I typically, with this one, go off-label and use a 3 ml dilution. And the reason for that in my practice is that it's a push feel that I'm a little more familiar with. Of course, Botox was out first, and with a 3 ml dilution, I feel like the push volume is approximately the same with both. The other reason I like the 3 ml is that it's very easy math. Sometimes at the end of the day, my math skills go down precipitously. With a 3 ml dilution, it's 10 units per 0.1 ml, which makes the math extremely easy even when you're brain dead. Yeah.
She's got 3 cc
Okay. So, so I typically will start in the orbicularis area. And again, I'm going to have generally 3 injection points, usually at the tail of the brow or the superior orbicularis, oculi, mid-orbicularis, and inferiorly. This is a young patient with reasonable cheek volume. I would caution that on an extremely thin-tissued female, which I have some in my practice, I'm very cautious in this inferior area, as you don't want to knock out your zygomatic major muscle and create a weird issue with the lips. Not an issue right here, but we'll do. These are really intradermal injections. The orbicularis oculi and skin are contiguous in this area. So if we go deep, we're really missing the target. Go ahead and scale up again. The nasalis origin, generally right on the side here, you can see the muscle movement and relax. Just a little deeper, like 10 units into this area. I'm coming around to the other side. Yeah, this is, if anybody's given a PPD.
So oftentimes, using special loops or things to try to do those veins, and the biggest complaint area is getting bruising.
Yeah.
Staying superficial, maybe that helps a little bit.
Staying superficial helps, trying to identify the reticular veins beforehand and avoiding going through them. Those are super important. And I like to retract the skin, which I think helps as well. We're not, there's less resistance with the needle. I also use typically a 32 gauge needle, and patients appreciate the difference between a 32 and 30 gauge needle tremendously. For those of you who are not using a smaller needle, I would recommend going to the smaller needle. Next we'll go up to the procerus. Go ahead and, again, give me a scrunch. So I'd like to actually grab the procerus muscle and go right into the center of it. Typically I do the same thing with the corrugator. Go ahead and scowl, and we'll identify the head of the corrugator, which is right here, and the insertion point is deep down onto bone.
So this is a deeper head, Dr. Moss showed the histology, origin, corrugator, very awesome. So this is where we get deeper.
Go ahead and scowl again. Tail of the corrugator, I'm staying more superficial because the insertion really is in the skin on this tail of the corrugator. Go ahead and scowl again and relax. The length of the corrugator muscle is variable, so you really want to not have kind of a set template, but identify where an individual's corrugator is actually, where the head is, where the tail is, again, rather than kind of going from a set template.
Can you tell us what was your total dose there for the, let's just go with the crow's foot area, what was your dosing of the support there?
So 10, 10, 10, 10, 10, 10, 10, 10, 10, 5 and 5, just because she's doesn't have a lot of movement here. Coming up to the forehead, there was a recent paper showing that more superficial injection of the frontalis actually was less likely to cause heaviness of the brow. So staying closer to the skin, this is obviously a thinner muscle, which basically is pretty contiguous with the skin. So I do like to keep these injections fairly superficial, closer to what we saw with the orbicularis paper, or the orbicularis muscle. Go ahead and raise your brow. And we want to we keep her from having that Spock or Mephisto, but we also want to make sure that she retains a feminine arch to the brow. So there's a little bit of a balance there. I typically do more what people refer to as the microdosing of neuromodulators. So smaller amounts in more places versus kind of your big bolus in just a few spots. I like to start with this lateral brow area, mostly to make sure that it's not forgotten, because it's the worst thing when the patient comes back with a spocked brow. Go ahead and lift up again, and we'll see she doesn't have a lot of superlateral movement. Again, we're going to keep these superficial and try to avoid the vessel. Turn towards me just a little bit.
That's probably the most common reason for repeat treatment or a touch-up, getting the high arch and lateral brow. Identifying that and getting through diagnosis. But even to today, I still sometimes have that happen. Patients come in and they fix that really quick.
Yeah, and sometimes I will say that the frontalis extends beyond what it's supposed to. I mean, it's just, some patients have a little more pull laterally than they should. And the other issue that we always need to pay attention to is just asymmetry. So just like our face is asymmetric from right to left, the musculature often has asymmetry as well.
Can you lower your hand just?
Oh.
I'm just, when you're pointing it out,
Yes.
the one hand was in front.
Thank you, yes. Okay, so, do some. Again, very superficial wheels. So surprisingly, there was no less efficacy and no decrease in onset of action with these, again, more superficial wheels as compared to, the deeper wheels going into the, sorry, my dear.
So in this patient, you have a lot of latitude to treat a lot of different cows because she's young, she has good skin, turn, and whatnot.
Yes.
The older patient that like has more atrophy really is dependent on that front house. Maintaining the relative position that's typical. And we'll have them tomorrow about to identify asymmetry of brow position of ptosis, right? Because some patients are compensating with the brow that might have a little bit of context ptosis. So that's really evaluated.
Yeah, very, very important to, I do tell patients, it's better to have a few lines and keep your brows elevated than to just make it, a smooth lake with depressed brows. Heavy brows make a person look tired and unhappy. And none of our patients like to look like that.
Okay, we have the camera, Dr. Moss will be getting ready for some CNN.
Okay, so we're ready. This is an established patient of ours from California, who everybody knows. And I'd like to, while she's here and on screen, we can say thank you for all the hard work that Marissa has done during the conference, and I think she deserves a round of applause. All right, that's golf clap. What you got? Okay, so give me a squeeze here. So first of all, I'm using Xeomin, and I'll start with that. With Xeomin, I think.
Corey, can you speak up a little bit?
Xeomin, yeah, it's unfortunate. Maybe I don't use that. I gotta figure out what my microphone's on. Xeomin is a serotype A is a serotype A neuromodulator. It is the one that I told you is stripped of all of the complexing proteins. And in our early experience, we found that it worked just as well as Botox, which is, and Dysport, which was the only two available at the time, except it didn't last as long but it's so much less expensive that if you want to do it, you can throw in another 5 units and get really the same duration. We already know about dose duration curves. And so instead of doing 20 here, I'll do 25. And they did a world tour of We're the Same as Botox. You know, that was back to about 5-10 years ago. But it really, you can get the same effect if you just use, in my hands, a little bit more.
Can you guys hear? Corey, I think we need a mic enhancement.
Okay, he's going to reposition the mics. They did some funky interface with the master board that we don't know about. So we had trouble with the mics yesterday.
We maybe get it a little closer.
So the Xeomin, what I was saying, I just use, it's a lot less expensive, so I'll use 5 units more in the glabella and 5 units more in the frontalis, so I'll use 12.5 total on each side. And I'm just grabbing her club head of her eyebrow here, and this way I come from the same side on everybody, so you can see this pretty clearly. And that's where the biggest part of the muscle is. And so, and then, you know, introducing it is, you know, just a little tiny pinch. And I don't like wiggling the needle too much, but if you can get more of the muscle, and slow injections, I think, are key to avoiding the potential of having, you got to turn that master volume switch down. You get feedback. That's the master volume switch on the board over there. So, if you have a little reflux, a little drop of blood, just don't push too hard because it's going to go away. And if you really start mashing on it, you're going to move the product around. You want it to bind it where it's supposed to be. And then I grab the lateral and the club head of the eyebrow, and then still at the superior brow, and just below the skin surface, I'll do another, you know, with the standard dosing, it'd be 7.5, 2.5 units laterally. In this case, it'd be more like 8 and 4 or something, 8 and 4.5. So, and then on the other side, I'm going to do the same thing. And so the nice thing about Xeomin, of course, and the theory was initially that, and this may be proven to be kind of true in neurology, is that they don't have as much of the complexing protein. And if you have less protein, you have less chance of tachyphylaxis or antibodies. But in our applications where it's typically going to be a lot less small, it's going to be a lot less than the, I mean, neurology, they want to get 1,500 units in their patients. They're typically staying around 1,200. I don't remember what the on-label indications are for some of these major spasticity things, but they, you know, they're totally happy getting it. And I had some trapezius spasm was treated with it, and it really does work. So the products are, these are wonder drugs. Anyway, small drops, and in the forehead, as I said before, if I'm going to do 12.5 units, but raise your brow way up for me. So,
Corey, before you get to the,
can you lower
forehead,
can you lower
Jim asked me a question about if people have deeper furrows, do they tend to get more ptosis? Certainly, I think as ptosis used to be a pretty rare thing that we saw, but with the increase of use of the botulinum toxins, we've been seeing a fair amount in our practice. And I think that, Corey, you know, you were kind of going fairly deep as trying to get corrugators and Proceras. Do you think, in your experience, that increases ptosis compared with, I mean, we're going for deeper muscles, they're below the orbicularis, but I can't help but feel that when I've gotten ptosis, it's because of those deep glabellar injections.
So that's a good question. There's a couple buried in there. But the one thing I would say is that you can see I'm almost going parallel to the patient's brow or her frontal bone. So when I'm lifting this up and pulling it away, I'm injecting the muscle. I'm not really going deep. I'm moving it along the muscle and perpendicular to which I think you and I agree on this, that it's either the foramen or in about 20% of people, they have a notch. She has a notch. And I think every time, if you do see atosis, I only see atosis once every 3 or 4 years now. They're mostly in study drugs. But, so it's just hard to know statistically. But I'm going parallel to the muscle, and that way you get more of the product into the muscle. I'm not going, like I see a lot of people going straight at, with the needle going straight at the target site. And I'm really doing the other way. I'm lifting this away and then going perpendicular, and really parallel to the muscle and along its pathway. And on this one, I'm really just subcutaneous and lifting it away from the frontalis. So, but I think the notch and the foramen are probably the best explanation for why people get this. A few molecules drop into the superior orbital fissure, and that just doesn't take very much and it only lasts for a couple weeks, so it's really just a couple molecules that get there for most people. I think plunger pressure plays a big role in that, and when people are new at doing it, that's a problem, because you just don't really know. But if you use light plunger pressure, there's less chance, in my opinion. Those studies have been done to prove that, but they're out there. I also will say that I now we're using a lot of this stuff, and we're using it I promote. I mean, they're here, but this is hypochlorous acid, and we actually make it in our office. There's the chemical formula for it, and we wash everything down with it afterward, and it really kills everything. So it's a nice study. You saw, I'll speak on behalf, Patrick Bitter's not here, but he had his nurse literally spraying the whole face and spraying his gloves and everything while he was working. So I'll have you raise your brow way up and relax. I don't think you can hold it any closer.
Oh yeah, we can. Yeah.
Corey, what was your dilution on?
We use it's reconstitution. We reconstitute with Xeomin at 2, and do the same with Botox. And we do 1.5 with Dysport and raise your brow once again. So I kind of made two little triangles here, dot here, and then I raise your brow way up. And then I'm always looking up at the hairline, because if you leave little lines at the hairline, and these are just tiny little drops at the hairline, and that way they don't get I call them giveaway lines, where they're smooth and right at their hairline. They got those little lines that you can tell they got some type of neuromodulator. So she got 12.5. So the reconstitution is 2 ml. We usually put 2.1 in because you lose about 0.1, and I'd rather have a little extra diluent than a little less. And then when you pull it into your syringes, and we make them all one bottle at a time using these insulin syringes, pull it, take the cap off, pull it out, and have them in the refrigerator with a set number of units in it. And then we have some touch-up syringes that we keep in there too that might have 5 to, well, anywhere between 3 and 7 units in it, let's say. And I think that covers it. Oh, and so her dosing was 12.5, forehead 12.5 on each side, and I'm going to do the same thing with the lateral canthal lines here. So we always draw these with the Xeomin. It would be drawn up a little higher.
We've been using a lot of Xeomin in our practice, and for those who aren't, and it seems to be the training across the country that way. And patients like it, my staff likes it. Apropos the talk this morning about your staff needs to know kind of what's going on in your practice. And in terms of starting with Xeomin, whatever you're doing with Botox, I would personally just start with the same with Xeomin. Maybe you need to ratchet it up, but it's very interesting the differences in these drugs. They tend to be very patient-specific. My original background with Botox, even before it was Botox, was in its original licensing, was in functional use. And there's no question that there were patients who would respond to Botox, would not respond to Botox, but would respond to Dysport, or would respond to Xeomin as they came out. So again, you might want to consider, keeping enough dose Xeomin like Botox. Corey, I think you up-dosed a little bit on Xeomin, is that right?
Yeah, so I'm doing 12.5 units instead of 10, but it doesn't cost any more if you do that, so you're really doing them a favor, and it lasts at least as long, if not a little longer. So I make it fair for the patient too. If they're getting really high doses, I have some patients that have some resistance, some tachyphylaxis, and the default for those patients is Xeomin. And there are a lot of male patients who have really heavy lines and deep corrugator muscles, and those patients really probably got such high doses at such frequency that they do have some blocking antibodies. I've never had them draw it because it's not going to really do anything for you. But that's I think something you can do, and send it off and see if they have blocking antibodies. All the studies require that they do. I need a small one now for a little. One at a time.
Stuart, do you use these drops for doses?
Come out, and it's basically after-nose spray, oxymethanol. And it actually is probably its best use is probably for post-neurologic ptosis rather than treating other forms of ptosis just sort of out of power.
So I'm doing an upper lip here, and I will tell you that I'm not, you can get the Daxify off the screen. But you don't want to do a lot, and if you start with somebody who, you first of all warn everybody that they may at the 2 week mark, 2 to 4 week mark, they may really feel the lip dysfunction, but you're really looking at its effect over the duration of the treatment, which is 3 or 4 months. So it does make the lines better. It's a supplement to treating, with the filler, or to treat with laser skin resurfacing is actually, or doing.
Corey, do you find it is a quote lip flip, which is kind of popular, certainly with fillers. I don't have a lot of experience, but there's some chatter about what you just described, creating a bit of a lateral lip flip.
Yeah, I've heard of patients come in and ask for a flip. It's not lift. It's in case that was some misunderstanding. It's a lip. It's a lip flip. And I don't understand the mechanism of action, but if people want to actually get a little bit in there to try to make their lip look a little better, that's fine. I'm just doing some fine lines.
So your main target is the fine lines.
Yeah, so I did this because she was sitting here, but this is really a truly intradermal injection. I get a little, it's not extrusion, that's where I'm a little superficial. But I'm lifting this up without bulking her chin up, which I've seen so many people come in with this bulked up chin, and I try to get them away from that strategy where you're kind of going down here below the skin and lift everything up, because it really does make the chin larger, which most women don't want a larger chin.
I think you can do most of these techniques with any of the products.
You can, yeah, for sure.
Doses. There's nothing inherent with one product over another to do one of these maneuvers.
Yeah, I do Bellatero for this, or RHA1 now, but they have the least amount of Tyndall, but this is down to about 8 line that she has, that very that line here. So, yeah, you're at the other screen now, so that's fine. Anyway, we've done it. It's really a fine line treatment in our hands.
So Corey, we'll let Jim start talking about Daxify.
Okay, great. Well, so this is the new product that we're going to be showing today. This is the Daxify. A couple of unique things about it. It comes non-refrigerated, so it's similar to Xeomin in that respect. The vial is a small vial, okay? And I'm just going to bring it up here to the forehead so you can zoom in on it. So it's a small vial. It is non-refrigerated. This vial has in it 100 units, okay? So I'm going to talk for just a minute about the reconstitution. So we use whatever volume that you're using for Botox, okay? You basically want to use half that volume when you reconstitute Daxify. So in this case, I normally use the Botox at a 3 cc reconstitution. So in this case, we have added 1.5 cc's. As Dr. Moss said, he uses 2 cc's for his botulinum toxin. So to get the same kind of push volume, he would simply add 1 cc to this to have the same amount of push volume in your product. So I just want to be...
So Jim, you're basically saying it's kind of, you're going to need to use 2-to-1 doxify in terms of units.
Yes.
And so units, because all our volumes are going to be kind of all over the place.
Right.
But so what you're saying is it's sort of a 2-to-1 compared to Botox.
Correct. And I think, on label for the glabellar study, it's 40 units, okay? I think we talked about earlier that with the botulinum toxin A from Allergan, it's 20 units. So I'm just trying to keep the math simple. So if you are going to try and try the Daxxify, you want to just half your volume of whatever you normally do if you want to keep the same push volumes for your injections. So that's what we've done here. So my injection technique is very similar to the previous demonstration, so there's nothing magic. We have our patient here who has not had a neuromodulator in at least 4 months. We're going to have you go ahead and make a strong frown for us here. Okay, and so the only thing with the variable anatomy, it's nice to see where that lateral dimple is of the corrugator, because that tells you where the termination is of the corrugator fibers into the dermis. And then we can kind of zoom down here and look at her glabellar complex as well, just to show, and a little bit of the nasalis lines as well. So I'm going to do the same technique that was just demonstrated, except for this syringe, okay? So I'm using a 0.3 ml. Normally, if this were Botox, I would have 10 units in here, okay? But because I just told you the reconstitution, I have 20 units of the Daxxify in here. And so I'm going to use 2 of these syringes to basically treat the entire glabellar area, including the procerus. So I hope that's clear. And then again, because this product is just coming out, we talked a little bit about the duration. I'll just speak briefly about the adverse events that is in the product insert. It seems that the adverse event profile is very similar to the other neuromodulators when it comes to the incidence of ptosis and headache and swelling and whatnot. So I'm again just going to come here. I just palpate. I usually start off medially here and kind of pinch up again the corrugator and come straight in and just put in. So I'm using the same push volume, okay, for each amount. I always kind of palpate where the supraorbital notch is, where my vessels are going to come, and just come a little bit lateral to that. And it is fairly a deeper injection for my first 2 injections. So I'm kind of all the way into the hub there. And then again, I'll just kind of reassess where the lateral corrugator lines are, and I'm going to come a little bit more superficial. So I'm about kind of halfway through with the hub coming out here. And it is true, when you come further out laterally, the patients will oftentimes feel it a little bit more, because that's where your deep branch of your supraorbital nerve is running. So if you go deep, they'll feel like a little tingle going all the way up into the scalp. So you really want to be a little bit more superficial when you come more lateral out here. Okay, so there's nothing magic about it. It's just the same technique that you're used to doing when you're doing your neuromodulator, but we just put in 20 units, okay, on this half of the forehead, and we're going to do the same thing. So the other unique thing about Daxxify that distinguishes it from every other neuromodulator is the fact that it contains no albumin, okay? So the albumin is, if you remember, this company started off trying to get their Botox through the skin, and albumin is a 64 kilodalton protein, which is too big to go through the skin. And so their stabilizing peptide is 5 kilodaltons, and that's where the science and kind of the discussions about Daxxify is that they use this smaller peptide to coat their core neurotoxin, and so that's what makes it different from the other ones. Now, as far as who really knows what the mechanism of action is, there's some theories about why the duration might be a little bit longer. Is there truly something unique to that peptide? I don't really know. But the on-label indication in the studies that get the 6-month experience with the published data is based on using a 40-unit dose through here. So if you have a patient In our practice, what we're typically doing is taking patients who either have shorter duration of effect with their previous neuromodulator, and we're selecting those patients to come in and try the Daxxify and see if we can get something longer, as well as those patients of mine who only come to see me like once or twice a year. And if we can get a little bit longer duration, either you're going to use that higher dose concentration that Dr. Moss talked about, or you can pull out the Daxxify and try it on them. So I'll go ahead and inject the other side. If there's any other questions, I'll answer them as they come. Thank you.
Any questions for Jim at this point? Corey, are you ready with your next patient?
I'm ready.
I'm ready with the question.
Wait, so all right, so we're.
He said he wasn't talking to us.
I was giving her a little squeeze ball. She'll hold it up for you so you can see. I think people will appreciate these. Some people use little vibrator machines and different distraction techniques, and I think any little thing helps. We also offer numbing gel or cream for all patients, which does two things. It helps to buy us a little time if we're running a little behind schedule, and it does work just with the needle poke, but it's very small benefit. I think it's more psychological than anything else. So I also like to give the patient the mirror, and we do that on everyone, and I'm not going to have you hold it too high because you won't be able to see, but you can lean your head down. And what areas were you thinking about that are bothering you? Because you look awful young.
The crow's feet here, and then I like to do my bands.
Let's give me a good squeeze of your crow's feet. Okay, so these would be mild to moderate at best. I'll talk louder. We're going to get these mics fixed. Mild, moderate at best. And then give me a squeeze with your bands. Yeah, she actually has real bands. So we'll get those. I usually do 10 per band. And her crow's feet are not very severe, so we're going to do the usual. This is Botox. So I don't do the 12. I do 10 per side. And maybe I'd give a little longer duration, but I don't know if it's worth the. We made a mistake early on, I think, with the neuromodulators and charging by the unit instead of by the area, but we're kind of stuck with it now. And then, with the fillers, though, we do it by area, and you can drop it.
Could you guys hear that? Could you hear me? He said he's converted over to more charging in his practice by area treated rather than by number of units.
Yeah, hopefully you can hear now. The audio guys have been
Much better.
So I'm just doing, these are sub-Q, but the muscle, the orbicularis muscle is attached to it, and you can see my finger here. I'm kind of pushing my finger or pushing the skin onto the needle rather than pushing the needle through the skin. And that seems to help with comfort a little bit. And then with the bands, as I said, I usually use, I mean, you can go higher if you want. She's got some pretty good platysmal bands. And 10 units per band of Botox, or 30 of Dysport, are fine. And then, and that lasts for the duration of treatment, which we're, for most patients, our average return visit is at 4 months. So I mean, some people get out longer, and nationally, when they study this is another thing that I would advise everyone, if you haven't talked to your local rep from any of the companies, but the data is pretty clear across the board. Patients come in an average of one of the studies is 1.7, 1.9 times per year. So they only come in twice a year, even though we think of the duration as being 3 months, where they come in, and some compulsive patients do come in 4 times a year, but on average our patients come in 3 times a year, which is greater than the average. So on average people, it's pretty clear just by default that a 6-month duration product would solve the problem. And we do a couple clinics where we just do Botox in the morning or afternoon, and we only do Botox, and we have a valet out front, and they drop the keys and they just walk in and they're out, and we won't do anything else. And that, we can get people in and out that way so they don't have to wait.
Yeah, I think Corey makes a couple of good points. The original duration for Botox was in functional use, and we needed to retreat our blood flow spasms and communication spasms. And for filler, you can drop off once a year. but you gotta figure out how you're gonna spend your money. And if you're just gonna drop by once a year, you're gonna lose a lot of the effect that you gain. And it is a cumulative effect, especially in the glabella. It takes patients about 6 months to really flatten out the glabella line. They won't move right away. They've got those deep lines like Jim asked about. It takes them about 6 months to pop those out. And so we try and make the point to the patients that they really do need to come back more often than 1.9 times a year. And I think in our patient population, we've done pretty well with that. And it's partly patient education.
Okay, so what we're going to do, we're going to do a little halftime show with Dr. Monshea here when we take a break. And Anna's getting her patient ready. I've got Hunter to come up and moderate her a little so she can see what's going on. But we're getting Anna mic'd up so she can give a little talk about
Do you want to turn this on?
yesterday about how she uses fillers in a way for patients who want to get a little bit of a lift without having surgery. So she spoke about her technique where she uses filler along the cervical mastoid muscle, along the diaphragmatic area of the forehead, which is like me. And Anna, are you getting mic'd up?
Yep, I'm mic'd up. Can you guys hear me?
Okay, I'm going to ask you to speak a little bit louder so you can get a nice soft voice, but just be a little bit stronger. And tell us which side of the face you're going to be treating and how you approach your patient here.
Can you hear me now? I'm on a different mic.
Yeah.
Sounds like you can hear me. Okay, so we are going to do the guanche lift on Michelle. And the beauty of this, do you want me to get started talking about it, or you're just checking my mic?
Go ahead and talk about what product you're going to use.
Okay.
We're going to do half of it right now. We're going to be taking a break. We'll come back and show half the face treated. And we'll come back. We'll show the audience.
Perfect. We're gonna do half face, just so you guys can see the results. I like to do halftime show. Michelle, the beauty of having Michelle back is that she was our model last year, and she loved it and mentioned to the people who were looking for a model for me that she would like to do it again. And this is something that happens at my office all the time. People want to come back and get retreated. They loved it, so we're gonna do it again. So she's our after and our before, but it's been a year. And the results usually last 9 months to a year. So we're gonna do the guanche lift where I add volume. She still has a little bit where I added before. The best place is to fill with a hyaluronic acid-based filler. My favorite is Juvederm. Can I get one? 1 second, you guys. Thank you. Yes, thank you. I like to use Juvederm, and sometimes I use Revanesse as well, and sometimes a combination. But basically, we're filling the reticular dermis and the dermis in these areas. So we shouldn't be as deep as where the vessels are, but the superficial temporal artery is what we're watching out for here in this area. We start all the way up here where there's a very bound down skin in the upper temporal area just before the fossa starts. And then I inject this entire region because that lifts the face up and backward. So the lateral brow will lift up and the lateral face will lift up, and this is a redraping of the skin just because it has to cover the new volume. We're also going to add, for the second type of guanche lift, is where we add volume over the mastoid bone, and she has a little tiny bit of residual volume there from last time. This just augments the mastoid bone area, makes it look more prominent, but most people don't know how prominent your personal mastoid bone should have been because everyone has a little bit different shape of anatomy, so it doesn't really, alert anyone, except maybe the first 2 days after injections. If there's little bruises and needle marks, the husband or family member or someone that sees your hair up might say, what's going on behind your ears? So basically we add volume here, and it lifts in this vertical vector and lateral vector, sharpens the jawline. So she's had this before, so her drama of her results will still be good, but not as good as the very first time you do it, but it'll still be amazing. And then I'm gonna do a little Volux along her jawline here, just sharpen it. We're gonna do a little softening of the nasolabial and marionette lines. I like to use Juvederm in that area. The lips will do Volbella, and I might do a little bit of the picket fence technique to evert the lip a little bit. So I like to do a global zhuzh. So guanche lift, jawline, nasolabial marionette, and then lips. So we'll do just one side so you guys can see.
And can you speak a little bit about
Oh, well, Juvederm, because I love the fact that it's hydrophilic. So the same reason we don't want to use it on the tear trough area, because it collects water, is the exact reason why we want to use it for the guanche lift, because we want maximum fullness, maximum lift. So we're actually saving them money. Versa is a very well-priced HA. It's very consistent. So a lot of times I will use that as well, even in the same procedure. That's actually a very nice filler if anyone's tried it for mid-face as well and lips. But, you know, I have armamentarium of all. I have a lot of different fillers that I like to use and play around with, so that's kind of how I just come to conclusions based on what I see after I do my injections, what I feel my patients look like, and how long their result will last. I found Juvederm lasts a really nice long time. Any other questions?
You can't stick two microphones right next to each other.
What happened?
We don't have.
Am I too loud?
Well, we can move the mic off. If you're gonna hold it, then
Oh, leave the mic off and just use this one? Can you guys hear this one?
either one, you can take that one off. Let's just
Or
turn
take
that
this one off?
Yeah, you just turn it off.
Okay.
Then you won't get feedback.
Okay.
And she'll stand on that side if you want, but why don't you stand on the other side? So sure.
Might be.
And you know, is the airline for the capital adjustment?
What was it?
Are you,
What did she say?
Do we know?
are you numbing the what?
We do not anesthetize the temporal area. It is so not sensitive. It's pretty shocking, actually. And the mastoid area either. And in fact, that would be kind of messy for their hair. In fact, that's the biggest complaint I get. This is a no downtime procedure, but a lot of people will complain that they just got their hair done and now it's full of Hibiclens. So I do prep it with Hibiclens. There's numbing in the injectable. So as we keep injecting, it's more and more numb and more tolerable. And we really don't have any issues because that area is not super sensitive. My hand's in front of the camera. Last time I did this, you guys were like, why? I can't see what you're doing. I have this habit of putting my other hand on either side of my injection site. My fingers, So I'll try not to do that this time. And then I always have my right hand, Jenny, who's amazing, who drove all the way up here from LA, helping me, and she keeps me sane, and she's amazing. So she'll be handing me the syringes, and we mix it 1-to-1 with lidocaine without epi. I never put any epi mixed in with my filler because I want to see a blanch. So it's mixed 1-to-1, and then she refills it from the Lurlock connector so that we just kind of keep a flow going when we're injecting, because it's a lot of syringes. So we'll probably put 3 or 4 cc's on either side here. And remember, 1 cc is 1/5 of a teaspoon. So just like when your kids were little and you gave them 5 milliliter Benadryl or whatever you gave them to knock their asses out, that is only 1/5 of that little cup. And so it's a lot for the lips, but it's not much when you're redraping the face. Feel free to ask any questions while I inject. My favorite place to start is right up here where it is very bound down. I could feel that she has a little bit still there. Oh, see, I gotta change my technique. Here we go. Oh, you okay? Mm-hmm. How bad is it? Tell us.
Not bad. Ooh, right there.
Uh-oh, right when a patient says not bad, almost every time they'll be like, ow, that one hurt. We do something called the gateway technique where we rub or tap or touch the patient somewhere else on their body. We ask them to focus on that area, because that way they get distracted. There's a whole science behind that. Apparently your ganglion cannot process pain and other sensation at the same time, so it has a feedback inhibition. And here's some Versa. No problem to mix HAs in my book because they're both inert. The whole reason we love HAs, hyaluronic acid, is because they are inert. Generally. Occasionally, with the cross-linking can cause some kind of reaction, but most of the time, you're basically placing something that doesn't chemically interact with anything else, so it's okay to blend them. Thank you. Are you okay? Is your arm getting tired? You sure? I did this ad, you guys, for a company, and they made me do like a bunch of videos of me doing selfies. Oh my God, I had to hold my camera for like 3 hours. I could not believe how your arm gets sore from something so wimpy. How do you feel now? Are you feeling okay?
Mm-hmm.
Good, I can whisper and everybody can't hear me. Okay. Any questions, you guys, please feel free to ask. And this guanche lift is something I invented selfishly for myself. And most of my patients are very much like me, so they enjoy it as well. We have a practice in Calabasas and another in Beverly Hills, and the patients don't like downtime in my office. So doing one of those crazy resurfacing procedures that some people do, and more power to them, our patients don't want that downtime at all. They just want to not miss a single thing. Okay.
That one hurt a little.
That one
We have
hurt.
a question.
Yes.
Is it Ultra or Ultra Plus that you use?
I like Ultra. And everyone who works at Allergan knows that I'm crazy because that's my favorite one. There's a bunch of ones that I like, but that one's my favorite. If my patient loves their result, they come back and they want a longer lasting result, we will switch to Voluma. So we will switch to Voluma. We charge a little bit more, but the value is much greater because when you switch to Voluma and it lasts, in my book, almost twice as long, you're really giving them, and we're not charging them twice as much, so they're getting a nice value for that.
And the Voluma, you reconstitute 1-to-1 as well?
Yes, 1-to-1. And I'm not concerned with bruising. They have really no downtime, nothing visible on the surface of the skin. So I'm just going into the dermis, reticular dermis, in this whole area from here down, and I'm going to go above here. Where you don't want to inject, in front of the joint, right? That's where your facial nerve and artery come out. Of course, superficial, you're fine, but just that's not where we're trying to lift from, right here in a visible site. So you don't want to go past the arch of the zygomatic arch. The truth of the matter is the vessels become more superficial towards the temple, and we do a lot of temporal filling, and we've got those techniques down. And so this is actually less sort of risky in a sense than filling the temple itself. That's the little area that's the danger zone. Now, people that get this procedure also become a redhead for a short period of time. It just depends. So at the end, we will put a little bit of hydroperoxide and clean it off. But like I said, their hairdo, whatever, they fix their hair. Now, last time you got this done and you went to dinner, the faculty dinner, right?
Tonight, too.
And you're going tonight. Did you feel like it was a big deal? You just went the same night? Yeah. That's the beauty of this thing. Love it. Sometimes I feel like when I don't feel that great or I want a little lift, I do it on myself. And the beauty of it is it doesn't change your face or get boggy on your face or weigh it down or look unusual. Let's see you. We can already start to see a lift here. If you guys can see that, if you can pull back on the camera. I'm not done, but just to give you an idea. So you can see this injected side here, and you can see that the face is actually looking slimmer already and lifted upward, and the lateral brow is lifted as well. I'm sorry. What's she saying? Can you hear me? I can barely hear you. You sound really like you're underwater or something. What did you ask me?
We didn't see the lift. I wanted to just point out, and there's an article in neurosurgery that looked at where doctors think they're injecting and the histology where they're actually injecting. And something like, like 80% of the time, neurologic surgeons think that they're in the dermis or in the subacute. It kind of speaks to this point where you get some vascular, reflux here. So do you try to get like a peau d'orange kind of?
No. Peau d'orange?
Right under.
I am right under the skin. Honestly, I've been injecting for 20 years. I've been trying because I'm going to start a course to teach this procedure.
No, it's good.
I'm trying to find.
Or in dermis? Under, right?
In or under the dermis?
Am I in the dermis? Ideally in the dermis and reticular dermis. We want to be where the tissue is tense, and there's a couple reasons why. One, I don't want it too deep because of the vasculature, but also if you go really deep, I feel like the tissues are slippery and the filler will sort of slide. That's when it migrates, right? You want it between those tight collagen bundles of the dermis. And even in the reticular dermis, you have something to hold that filler in place. If you do it too deep, the vasculature kind of clears that away faster. I feel like it doesn't last as long. But also, it's riskier. So why would you do that? And I don't want it to act like a tissue expander per se. I want it to be expanding inside the dermis, not underneath like a ball of filler underneath the dermis, which I've seen people do boluses, and it does work to lift the face, but you worry when it goes down what's going to happen as far as increased laxity of the face.
So the issue here, I mean, is that anatomically we know that you're probably injecting a depth of hair follicles, because the dermis is very, very thin. Once you go beyond where the hair follicles end, basically the temporal fascia, where all the vessels are running. So you're probably just like injecting on the hair follicles.
Hair follicles, okay.
And so,
You guys, I apologize that I honestly cannot hear half of what you're saying, but I think you said hair follicles. And, you know, we in dermatology constantly remove cysts and pilar cysts and such from the scalp. Any growth or anything that dilates, you know, the tissue in that area will make the hair look more sparse. I've had 2 cases where I've reversed this procedure. Neither one was because of hair, but both times the hair went back to exactly like what it looked like before, because it's not a change in the actual density of the hair, it's a change in the expansion of the dermis itself. So the hair looks more sparse.
it has to be in the light line, if you will, that will be if the product is going to obviously stay superficial, and that's why there's this kind of expansion of those tissues and that's what's translating through there. And can you talk a little bit about the area that you're injecting right now? Are you going to use a higher G-prime type filler back there to the scalp?
Are you going to use a higher G
Can you
prime
come,
type filler?
I'm sorry?
Are you going to use a higher G prime type filler in the back?
The mastoid area, using up the temporal parietal area.
You know, I have to apologize that none of us back here can actually fully articulate what you're saying. It's because, I don't know, the audio, it sounds very underwater, so I'm not exactly sure what you asked me. Can you, I don't know if you want to come ask me over here, or?
He's coming.
Oh, he's coming. Oh, okay.
The question was, are you using the same product back here that you're using
Oh,
here, or would you
yes.
use a higher G prime product back here?
At the moment, I use the same. I use the same exact filler in both sites.
Or both sides?
Yeah. I think the mastoid, though, is really, honestly, less risky in a way. The things that we see patients complaining of is a little bit of achiness and maybe even like a tension, like pulling headache on their neck, you know, just from the lift itself. But most people immediately, when I fill the mastoid area, feel a lift on their neck. I don't know, do you feel it?
Not yet.
You don't feel it? They'll feel this pull and this pull. In fact, I feel it when I do it on myself. I'm like, yeah. Are we almost done on this side? Okay. We're almost done with this side, and then we'll just see straight guanche lift results, which I'm always excited to do a live demo because we get to use unlimited products. So the discussion ends up happening in my office of how much product the patient can afford. And so we do a tiered pricing, and obviously don't expect to make the full amount that we get per syringe when we do single syringes. So
How's my jaw?
it's looking so sharp. Look at that. Do you guys see that it's starting to really pull both this way and vertically? But when she sits up, I'll have her sit up and you guys can see. That way you'll see just the isolated one. She did get a little numbing of her DAO, it looks like, because when she talks, that's just from the numbing that's in the filler here. And so this side's lifted a little bit, just temporarily. She looks great.
Okay, fantastic. So thank you for, it's always wonderful to show these kind of half-hour things. And obviously, what do you tell patients the duration of their effect should be? That's the last question.
With Juvederm, it's 9 months to a year. with the HA fillers that I use. Actually, I have various ones that I use, but 9 months to a year. And then if they use Voluma, it's a little more expensive, and I'll tell them it'll last about 18 months. So yeah.
Thank you very much. Let's go to camera.
Okay, can you hear me?
Speak up stronger.
Speak up stronger.
Really mad.
Okay.
Yeah.
Okay. Can you hear me now?
Yeah.
Are we? Okay, maybe. Okay. I have the defective. We're going to change it to the non-defective. Okay, much better. Yes? Yay! Woo! Okay, so this is Lindsay, and she's young and beautiful. But what I will say is, one of the earlier changes that we see with the aging face is, she's got great chin projection. It's just this lack of structure, this beginning kind of volume loss, basically between the chin and the melolabial fold area here. A little bit of structure of the ligament is going to give some lift and a little greater transition to this chin area. Additionally, put a little bit of filler into her nasolabial fold. I'm using Refine and Define today. I'm going to use just a little Define under the zygomatico-cutaneous ligament as well, just to give her a little boost to the cheek area. Little bits in lots of places. With Refine, I'm planning to address the cutaneous upper lip. She's starting to get this little fold on the lateral corners, which we see with a lot of our patients. So I'm going to smooth that up, give her just a tiny bit of production, external projection of the lip. Very subtle.
It's the art. It's very low.
So I'm going to start with. So she's been prepped. I'm obsessive compulsive about re-prepping my patients. So I'm going to actually address this chin area from the underside up first, and then use a demonstrative cannula injection to smooth over. So we're going down to mentum here, and I'm
Where's the one that's missing?
directing my needle upward, superior to the chin, so the tip of the needle is right here.
These are the receivers.
We're just giving her a little transition from the chin, projection around. And again, I'm always aspirating when I'm using a needle for a good 5 seconds prior to a slow injection. And you may be able to see this transition just lift up. So from a single insertion point, you move in both directions. This technique I find extremely useful and actually fairly expedient for virtually almost all my female patients. Everybody tends to lose a lot of structure in this area. We're going to switch over to a cannula. And I'm going to have you turn my head this way, Lindsay. Very subdermal, small threads, but we give just a little more support to the corner of the mouth. And when we lift your chin up, in the same insertion point, we can keep up into the So this was the right side, which tends to be a little lower. Most people, I would say more than 90% of people, have greater jawline on the right side, and the male prominence actually is lower on the right side. And actually is actually fairly symmetric with some softening in this area. Go ahead and set that for us. You guys can appreciate the subtle but dramatic softening on this side of the face. And I'll do the same on the other, but I guess we can go back to the other camera.
Okay, on, so you're back, finishing up on the other side. And, that's going to do, pick up all your finishes on the scalp. And, your skin is doing the same thing on the other side, anything different on the right side?
I try to keep it, I try to keep it consistent from one side to the other. I don't, occasionally my patient will ask me to balance them out, and I will, sometimes do that. But most of the time, my guanche lift, I put the exact same amount on either side. But again, once in a blue moon, somebody will say, I really have, and they really will have more drooping on one side than the other, and I'll just either just do that side, or I'll do the more on one side than the other.
My left side droops more.
Can I get gauze? I like to just smear blood all over people. This is our vampire facial. Let's see. So, and the other thing is we usually have like as we go pressure, but we just don't have the setup that we do at home, because you know what I mean. It's just different.
So in your presentation yesterday, you mentioned that you have been doing this for the past 5 years, and
Yes.
it's a popular treatment in your practice. And some of these patients have had previous facelifts, and then do you ever do this on a patient who's a little bit younger, maybe has not had facial surgery yet?
That's a great question. Absolutely. I have people in their 20s sometimes. They tell me, I want to look snatched. They come in and we just do maybe 1 syringe per side, 2 syringes per side, and just give them a little sharper look to their jawline or their face. And it can be at any age. It can be after a facelift. There are many patients, our patient here, can I say, has had a facelift. So, as you know, over time, things change, even if you've had a facelift. And what happens is people don't always want to go through that again. They just decide that they don't want to do a whole facelift, so they want to do something to look better in the meantime. And honestly, if someone's had a facelift, the way they've healed their incision areas, the tissue is really nice and bound down, so when I put the filler in, it really does lift nicely if they've already had a facelift. Just because that dense tissue that's under there, the collagen bundles really hold it in place and help anchor the lift. When you put a lot of filler in this soft area of the face, it looks great in the beginning when you start filling cheeks and such, but what happens is this tissue does not hold the filler up where you put it. It starts to like drag down only if it's done in excess. I still love cheek filler. If you do it here where it's bound down, it tends to hold its place and in fact anchor the rest of the lift. We're just filling nasolabial right now with the Juvederm. So I do still do the nasolabial. Some people opt not to do it at all. It's a small amount that I do just to complete the look. And this is not part of the guanche look. This is just me demonstrating injections. But.
So what should a patient typically budget for this kind of full comprehensive lift? What should they what should they be thinking about? Just give a range.
The range is, it could be as low as 1,200, right? Ask Jenny. That's what we say at my office. I don't know anything about it. No, I'm just kidding. For per area, so we quote it per area. So this area, zygomatic-temporal area, and then the mastoid area are two separate types of guanche lifts. So you can do 2, 4, 6, 8 syringes, and it's anywhere from 1,400 to 5,300, depending on how many syringes per site. And some people will just do like 4 syringes, so 2 per side here, and then they'll do 1 per side on the mastoid, and any other combination, 2 and 2, or we'll do a big one. Sometimes we call it the whale, like in gambling, and they come in and they just get, you know, something like 10 syringes altogether.
Okay,
So
great.
that does happen.
Well, thank you very much. Looks good. And let's give a round of applause to Dr. Monche. Okay, let's go back.
Okay, so we've used some define in the chin area to soften and smooth this chin transition, and I've used a little bit of define in the cheek to give a little lift and pop upwards, and in the nasolabial fold. Next, we're going to use some refine to address this predominantly cutaneous upper lip, to address the small fold that is starting to happen right there. In order to do this, I find it's important actually to support the lip itself, so you don't kind of cave into the area. So lift your chin up for me. So I'm going to first start by, again, giving a little structural support to this lateral lip. You of course don't want to overdo that, make the lateral lip big, but you just don't want it completely caving in. Women tend to lose the aperture of their lip. So we're coming up to the cutaneous lip, and this is with the cannula. I want to be very, very superficial, as superficial as possible, and create some struts across that fold. And I'm going to bring those up, actually all the way.
Is that a 25 gauge cannula?
This is a 25 gauge cannula.
1.5 inch?
Excuse me?
What's the length? 1.5?
Oh, 1.5 inch. 25 gauge, 1.5. You can see the cannula superficial as possible in the subcutaneous plane. And that just gives her, it's hard to see on the projection up there, but she has a smoother transition here without that fold over. The whole lip is slightly, slightly lifted a little bit. I'm going to actually create a few little struts just under the lateral lip as well, particularly as our patients get older, they tend to get that downward turn to the angle of the lips, which makes them look sad. Here we go. We'll do the same thing on the other side. Created my insertion points just a moment ago. Over. Always important to keep the patients. So we need light for you. Is there no light?
We need light.
Oh, sorry, somebody in the background. Yeah, one caution I would give for this cutaneous upper lip, two cautions. A, you want to use a fine particle hyaluronic acid filler, like Refine that we're using right now. B, again, you want to stay very superficial. If you go deeper, either with a needle or a cannula, you're not really scraping the underside of the dermis. What will happen is you will end up volumizing that upper lip more, and the patient, doesn't look as good when they have a volumized upper lip. It looks really eepy, I would say. So I would avoid, even with a small particle filler, it is possible to give a little more volume with deeper injections. This method is nice for basically creating structure in an older patient as well who has developed vertical rhytids. You can, do a little fine tuning afterwards, but creating that structural base is so important before chasing lines. So that the cannula, 25 gauge or sometimes 27 gauge, depending on the filler that you're using, can be quite nice. You do have to be cautious with the 27 gauge cannula if it's used just because of the potential to puncture the superior labial artery in the upper lip. So please be cautious if there's a smaller gauge cannula. That's it.
Awesome.
Any questions from the audience for that demonstration? Define, we use that in practice. Okay. And going to be coming up next, using visiting fillers, and Dr. Grass will come back with one of the biostimulating fillers, polylactic acid. Is there a patient ready for Dr. Moss?
Dr. Moss is ready.
Okay, can we get a patient? So Dr. Sunder, what's your post-protocol for your filler patients? Typically, they're coming in, they're getting a couple syringes. What's your post-care? Minimize bruising, icing, any special instructions you give patients?
Yeah, I don't, for both the neuromodulators
I feel like that too. Oh, you look great today. Big screen is pretty good. Oh, big screen is
Projected.
Oh, yeah.
I don't think so. He gave you that.
Okay, very good, very good. Okay, Dr. Moss, with that, she's on camera now.
Yeah, we're waiting for a Sharpie here, but we'll talk to this very nice-looking young lady who has she's not a perfect example, but and I don't know how well the camera shows this, but we were talking about initially maybe doing a little bit in her nasolabial fold, and then she has a little bit of a tear trough depression here, which doesn't show. Can you lean your head down just a little bit? You can see a little better there. But and then she's got what this area here that's I'm going to just mark it. That's kind of a high point, which comes to a triangle, like an arrowhead-shaped area, where it's a little higher. And she has it on the other side too. And I call this the triangle of edema. People who have allergies have this, but I don't know if it has to do with lymphatic outflow changes, like you only go back, and then you have sort of a line of demarcation where the lymphatic outflow is down. And so these areas have a tendency to go up and down. And you can't, it's really hard to just correct them, but because she has a little bit of a depression along her rim and then a tear trough, we can do voluma for her midface and then maybe get her a little bit of a lift here. I mean, it's not going to be as much as my hand, like if we did a midface lift, but it helps really to support them. And then I drew this earlier, but it's a good opportunity to draw this and then turn this way just for the sake of the mirror. May I have an alcohol wipe? I'm going to clean the numbing cream off the other side too of her face. So we've put some numbing cream on, and that is betacaine, tetracaine, and lidocaine, commonly known as BLT. And it's not a sandwich, but a combo of local anesthetic topically, which is very effective. And people do notice the difference, and I'm marking probably 1.5 centimeters above her fold. I don't want to make it deeper. I'm found her zygomatic arch here, and I'm going to connect the zygomatic arch dot down here to where the fold is, and then the upper part of the zygomatic arch, I'm going to go right down to where her rim starts, and she's got a nice high rim. And in fact, her rim, and when you feel these bumps on patients, a lot of times you'll think it's a fat pad. I'm going to lift your chin just a little bit now and have you look up at my finger. And so she's got a little bit of a fat pad, and then you can look straight ahead. But she also has a very prominent orbital rim, and I can feel that it kind of drops off right here. So to take that into account and to treat it properly will help to attenuate the little bulge or the bag under her eye. That's what patients describe it as. So I've marked the nasofacial groove here, and then right along that rim, the prominent rim, so that we're lifting that up a little bit with the filler. And in this case, we're going to do some voluma. And then there's a depression here. That's the orbito-eye malar cheek groove. And I'm going to mark that too. And this is where her zygomatic arch sort of drops off precipitously. A lot like that drawing, and there's really not much of a depression here. That pretty much goes straight down. So it narrows the midface down to a very small section, which really needs it. And if you listen to the original teachings that were promulgated about the use, this was the last and most infrequent area treated with voluma, where it, to me, it seems like the most common and the most needed area of treatment. Because she's got nice high cheekbones, she really doesn't need any volume out here. It's really volume deficiency is in the midface. Sorry? Was that a question? So I've got some, and then I'll take another alcohol wipe. So I've got voluma here, and we're using a 28 gauge needle, the red needles. You don't have those? Oh, so you have a 30? Yeah, so you can use anything from what's in the box to down to 30 if you want, just a little more plunger pressure. I've already prepped this, so I'm going to prep it one more time. And then I'll start over here on the side. She's got a squeeze ball in hand. No, she doesn't, so we want to have that. If you feel the pinch, you give that a little squeeze. I need a sponge in my hand there. And I'm going to do, I'm just going to have you looking straight ahead. You see the little red dot on the camera here?
I do.
Okay, so I'm going to have you have a nice straightaway field of gaze. And I'm just going to correct for you. Feel a little pinch here. And then I'm going to just go slowly and let the local anesthetic in the filler numb her infraorbital nerve. And I would be in the submuscular plane here, so the suborbicularis oculi plane. And I'm careful not to inject which I see not, thankfully not often in my patients, but I see a lot of patients come to me that have disproportionately large fat pads where a filler was attempted around the orbit, and they're actually injecting the fat pad itself. And it's a pretty nice capsule around it, so it's, stays around a pretty long time if you don't inject it, and then you have to identify the fat pad if you see it and get enough hyaluronidase in there to treat it. And then I'm going to do one little drop out here on the side for you, pinch. And if you look really carefully, you can see the small vessels, but they're all going to be, for the most part, in the supramuscular plane. So in this orbital malar groove area, you can do it pretty effectively without a lot of swelling and just get it down there. And I know this isn't probably appreciated that much on the camera, but this was a dip before and is now nice and flat. It's not bulging, but it's also not a depression between the eye and the cheek. So that's a nice transition there. And I'm at about 0.7 ml. And I'm going to lift your chin just a little bit and turn a little bit toward me. And I'm going to do another drop right here, staying just below the rim and kind of lifting that up and just going slowly. Again, the antegrade technique is what I'm using. And I don't mind lifting it up a little bit beyond where it's going to be. And that's really right below that prominent rim that she has. It's like a little, if you feel it, it's like a little step off, like a ridge, if you will. And we're close to 1 ml, which if you remember from the study, which was a little bit of controversy, the average volume of Voluma used in that study, of course no one was paying for it because it was a study, kind of like a teaching event, but it was 7 ml, which is an awful lot of Voluma at $1,200 per syringe. So, that's it's getting up there. The highest volume getter with the Voluma had 13, and if you read this, you should read the study if you haven't read it, because it's, not really proportionate to what we're doing, but gives us nice upper limits for clinical practice, because if you can use that much on a patient and have a happy patient, you know what the upper limits of the value are. But I rarely go beyond 3 ml in a mid-face volume treatment. And again, I'm looking at her skin and trying to avoid the little skin vessels here. And doing an antegrade treatment here. All the way out to her orbit, right to what we like, what's described as the teardrop depression. And so I'll be able to show you a little comparison here in a minute. And the two sites can have an alcohol light. I'm going to take this. I got one more drop to do here first, and then I'm going to take that off. So again, small drop, submuscular. This is suborbicularis oculi plane, and just real slow treatment. And then, how would you describe the level of pain on a 1 to 10 scale?
Not even a 1.
Not even 1. I like that. That's good. So I'll take the alcohol here and I'll treat you. And so I'm going to get the ink off of this, and then a little bit of this is swelling. She doesn't have any bruising if you stay in that submuscular plane, or the supramuscular plane. Really, kind of submuscular plane, I guess, would really be out laterally. And then just close your eyes, just and then look up above your head with your eyes closed. Can you do that? A little hard trick to do, but there's nothing to get the fumes. Yeah, so if you load, I put a little bit of local in with it, but you can do it either way, especially with a new patient. I think, make it probably not going to last, the 47% of the patients treated that were fully corrected. Of course, it was a large volume that was used, but we're still fully corrected 2 years later with this product, which is, one of the other downsides. I mean, there's an upside and downside. Duration, that's fantastic, but it becomes a lot more like a cheek implant, and there's a potential rate of the biofilms and things like that we were talking about earlier. And
Can you consider a little bit of aperture of the camera? It looks really good, and
yeah, I can turn.
the impacts and the smooth transition from the
Yeah, so that's untreated side, and then we come over to the treated side. Nice, smooth, round cheek. You can see some improvement in the nasolabial fold even. I don't expect it to be fully corrected. In fact, a lot of them will get a little bit in the fold. And, but that's the treated side. And I didn't do any, as you noticed, she has really already high cheekbone. You really need to do anything out there. And it really takes away that tired look that's created by the tear trough depression and just the general depression in this part of the midface.
Okay, great demonstration. We'll let you finish the other side, and we'll go to camera one, and read the demonstration there.
Because I'm a sculptor queen, right? No, I do love the product. Sculptra, as many of you know, is a collagen stimulator. It's purely 100% stimulatory filler. The effect that the patient sees is all them. So it is a more gradual product, but I think it's one of the products that we can kind of truly anti-age our patients with. We can actually reverse facial aging by having them their own structure build and regenerate. So one important thing to note since last year, Sculptra got an indication for immediate reconstitution. This was a hurdle for a lot of people. I use a lot of it, so I still have it already reconstituted with sterile water for injection in my office. I just add lidocaine at the time of use. The new immediate reconstitution, you add 5 cc's of sterile water for injection. Shake, 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 shake for 2 minutes. Add 3 more cc's of sterile water. Shake, shake, shake for 3 minutes, and then add a cc of lidocaine. So generally, the goal is for a total of 9 cc's of fluid. You get a little bit of methylcellulose foam. So in reality, we're injecting about 8.5, 8.75 cc's per vial. I typically use 2 vials per treatment session, 1 vial per side of the face. This is a great product for kind of overall structure, rejuvenation. I use my HAs for fine-tuning. Robin, who is, what's her name? Your age, that's okay, 60, has, and she's then typical biovolumetric changes of the aging face with, some bony narrowing, a little bit of loss of the zygomatic arch and malar eminence. We tend to get a little more rectangular, narrow, a lot of loss in this preauricular area, and a little kind of superficial fat and skin migrating forward and downward, which accentuates the nasolabial fold. A little bit of loss of the mandibular ramus. We're going to use probably some HAs off camera afterwards, but the structural part, Sculptra will go up into her temple, zygomaticomalar area, preauricular, the submalar hollows here. We put a little bit in the piriform aperture and put some up into her nasolabial folds. What I will do off camera is, similar to the last patient, a little define to structure the chin, some refine around the lips to smooth the very baby ratids, and a little volux in the lateral angle of the jaw to give her some pull and sharpening of this ramus.
For a patient like this, how many sessions would you tell her that she needs?
Yeah, that's a great question. So how many sessions? On average, I tell patients they need approximately 1 vial per decade of life. So somebody closest to 60 would need 3 sessions with 2 vials per session on average. But in reality, I'm often using hyaluronic acid fillers in conjunction, and a lot of times they'll need, maybe 2 sessions with a little HA to kind of boost and give a little immediate gratification along the way. Yeah. And an average, I tell patients an average is only an average. So half the people, 50% of people are on the upside, and the other 50% are on the downside. I have 40-year-olds that need 6 vials of Sculptra because they work out at the gym 6 hours a day, and they have no facial volume left in their face whatsoever. I'm going to start on the zygomaticomalar area. One thing that's important is making sure your product is nice and homogeneously milky, making sure there's no air in the syringe. I always express some product before going into a patient's face. And in this area, I am going down to bone and with each injection, I'm withdrawing prior to injection. I'm fanning the product right over periosteum. Feels like pressure. How's it feeling? Good, it's fine. There's a lot of pressure sensation, but truly, having had this many times myself, it's really not painful. I like to have this my injecting hand. If you can master the one-hand aspiration, it just goes a lot quicker. And on the underside of her symptomatic arch, again on periosteum there. Moving down to the lower hollow. And I'm pushing my needle kind of beyond where it normally would go to give a little more lifting effect. Going back up into the hairline, and right in front of the ear. In this area, of course, you want to be cognizant that you've got a carotid gland very close to the surface. So you really want to be in the deep dermal plane. Basically high-fat, subcutaneous, subcutaneous dermal junction. And lots of small, especially in the superficial plane, small aliquots on each withdrawal. So there should be about 0.1 to 0.2 cc's. See how many passes are used in this area. I'm going to have you open your mouth for me. So I'm going to put a little in this temporal hollow. And what I like to do is pull the skin back. I'm going to go down to bone. Can you see okay? And again, after aspiration, next I'm going to put a little bolus and piriform aperture. This one tends to be very sensitive because we have branches of orbital nerve that run right over the bone. So you really want to very gently tap and aspirate the lymph draw. And you put your chin way up. Right into the nasal labial fold. These are more superficial injections. And then fan really up to the center of the cheek. Very small aliquots. You want to be cognizant, not to give your patient kind of fat-low cheeks. This is just very, very tiny aliquots in this area will create some rejuvenation of the skin. The sculpt for glow. It's kind of nice for the full face.
Great demonstration of technique. We're going to come back to you here in just a second. I'm just going to see the final result on the Luma.
Sort of V-shaped mid-face that was hollow, and then she's got, you really already had nice high cheekbones. But once you do the mid-face, you can see that you get really nice accentuation of the zygomatic arch without even putting a drop of the filler in that. And that will last her for a couple of years. You know, she really maybe needs a little touch-up or something, but not very much. So she was a very good model, so thank you very much.
Thank you so much. Thank you.
The rapid reconstitution calls for 5 cc's, shake, 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 then add 3 cc's, shake, 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 and then add your, and then add your lidocaine to that.
So there was a recent change in the time to hydration of the product, if I remember right. It used to be that it needed to be mixed up at least 48 hours prior to preparation. And then was there a labeling change where you can mix it within an hour?
Yes. I mean, you can do it immediately before use, basically immediately before use. So there is no need to worry about products sitting on the shelf and not getting used.
So Jim, the problem with mixing the same day when we were using it a lot, we got more granulomas. The problem when we go to meetings, the consensus was that there were pure granulomas. You let the patient solve it. Is there some new message or change in product?
So that's a good question. I think that it comes down to the incidence of nodule formation was definitely with the lower volume mixing, and of course that started out with Newfield, which is like a 3 cc mix, and the incidence of nodules was as high as 30%. And then going to more than 5 cc, which is on label, as most of us do. The question is, letting it sit longer versus mixing it right away. And I think based on the study, they just found that if you mix it and agitate it up, which they usually tell us not to do, that the product would be hydrated enough. And Sarah, I don't know if there's any more info regarding that. Do you tend to let it sit longer? I mean, I still do.
So I do for 2 reasons. One is it takes a little while to mix, shake, shake, shake. I mean, I'm busy, and it basically is just more efficient for my flow to be able to take product off the shelf that already has water sitting, and I've been doing that for years, and it's worked well for me, so I haven't actually changed. The clinical trial data shows no difference in nodule formation with the rapid reconstitution. The nodule formation, granulomas are extremely rare with Sculptra. In fact, granulomas are much, much less common than they are with hyaluronic acid fillers, which hyaluronic acid fillers, granulomas are fairly uncommon, but they are less common with Sculptra. Nodules, I would say, are all basically user dependent. So if you put too much product in one area, you're going to get too much collagen built up, and it will result in a clinical nodule. So thinking of the product as basically little seeds that you're laying over the lawn, so to speak, versus basically putting a whole, pile of seeds in one place on the lawn. You want little bits in lots of places, which gives a very harmonious but also kind of confluent build of your innate collagen and probably other
How many people in the audience use Sculptra? Okay, quite a show of hands. Okay, very good.
So, excellent. Of course, your technique is perfect. You're one of the higher volume users of Sculptra. And what are the tricks for preventing it from clogging? Because it seems like there's a clog there.
So clogging is the bane of everyone's experience with Sculptra. It actually is pretty infrequent with the following tips. One is you want to draw the product up slowly, assure that all the air and every last bubble is expressed from the syringe before you put on your 25 gauge 1.5 inch needle. So for some reason, air and bubbles will clog a syringe. If you have any of them in there, it will clog the syringe. So that's super important. And then the other two things are, make sure the product's flowing before you put it in the patient's face or wherever you're putting it, before you puncture the skin, your patient's skin. So usually this is not a neuromodulator, so if you express 5 drops, it's just not the end of the world. Whereas, a little different with the neuromodulator, right? So express before you go in, and then always keep the plunger moving. So I am constantly either placing my needle and then withdrawing. The withdrawing actually helps to keep the product from clogging. So it's that constant back and forth with the withdrawing, injection, and drawing, injection, injecting. And that really actually helps tremendously. Sometimes when you do clog, a good hard aspiration can unclog the needle while it's in there. Sometimes it doesn't work and you have to take it out, but I find about 90% of the time, if I do clog, I can usually just dislodge. The other thing I would say is, often in areas that you're going to periosteum, you don't want to give yourself the needle a little bone plug. So a lot of times people I've seen go in and they really, really want to make sure that they're on bone, and they basically do a little mini bone biopsy on the periosteum, and that clogs the end of the needle. So tapping, not forcefully injecting into onto the periosteum.
Okay, thank you very much. Continue along there, beautiful demonstration. And
I am Mike Dodd. So just a quick clarification. So the Volox is going to be next. Our wonderful patient here was for contour, but we're going to apply a little bit of a Volox as well. Just for everyone's information, we are going to have videos on the website of this society as well. That is going to be free to you for all the members to observe as much as they want. I have also videoed 4 Volox patients at the office under better circumstances as well, and those are going to be available on the website as well. But quickly evaluating, obviously when evaluated, a wonderful, thank you, young lady here with great genetics, excellent skin. But we always have to be careful with facial asymmetry, so just to bring it to your attention, we're going to be focused on the mid-face and the right jawline. So when you look at the mid-face, the right side of the face is bigger and more lateral than the left side of the face. There's some hollowness right here on the just I would say medial to the malar eminence. As you have more projection, perhaps some prior fillers right here gives more projections and less of a lateral projection. So what we're going to do is place some contour here, hyaluronic acid. that is FDA approved for the cheeks to make that, just to make the contour and transition smoother. And here what we're going to place a little bit here and some laterally to bring some width to the face and some Volux to the angle of the mandible. Quickly, we're going to go ahead and perform the Volux injection. This is a perfect individual for Volux. Great skin and nice bony structure. Quickly, if we were to look at that, the axis of the ear goes in this direction. Antegonial notch is easily palpable right here. Facial artery ascends here and takes a course as such. Now, and facial vein as well. Here is the angle. Here is the masseter muscle. So this is our masseteric zone that ends right here. The mental foramen is about right in that area, and the mandibular ligament perhaps right about there. So in this area there is no muscle and not much of a vascularity, although we always have to think there are blood vessels under where we're injecting. And this is our mental nerve. We have to be careful with some of the arteries, the mentalis muscle, and the mental nerve as well. So could I have another gauze? Thank you. Then I'll have the Volux on you. Thank you. Some dry gauze. That's where I'm going to switch you with the one on my hand. Thank you so much. So we have already prepped the skin, but we want to make sure we get that nice anesthetic on. Quickly, what we have, the axis of the ear, angle of mandible. Our purpose is to really bring that more laterally. So I palpate posterior angle of the mandible, and in a deep subcutaneous tissue in a retrograde fashion, place 0.1. This is my preference, is to go ahead and inject in small amounts. The question is going to come right where the antegonial notch is. I want to bring your attention, that is most of the volume loss, right there. So you can't say you shouldn't place that there. This is a place that you're going to need more fillers. Here we go. Stay in a subcutaneous fashion. Retrograde injection. Just the difference already. So right now we're just making the angle of the mandible go straight, because the other side is, and now we are going to bring some lateral projections. So going superiorly, posterior edge of the masseter, coming lateral, placing 0.1. You can see how well this product is performing when the selection has been appropriate. Here we go. And very minimal swelling, that's going to be the result of this type of injection. I'm going to have you turn towards the camera. Can we go ahead and center on the patient here? Thank you. Chin up, just look straight at the camera. I want to bring your attention that now we have a lower lateral projection and you have a nice angle formation, more distinct and even throughout. I'm going to turn you back. Thank you. So now, could I have the contour syringe? If I may pass this on to you. Thank you so much. I'll have another gauze, clean gauze if I may. Thanks. So remember, our purpose, our objective was to make this transition as an arc. We have a slight drop here, and we also want to bring the zygomatic lateral. And a lot of times we have to place some of the parotid fascia. We're not going to do that at this point. Malar eminence, I'm going to use that as an entrance point, and I'm going to go anteriorly. This is as deep as I can place it. This is contour, retrograde. Now, I am in my hands. I always think, how does it feel? How does the tip of the needle feel? Do I feel anything that is a little difficult to penetrate? If so, I retract and re-enter. 0.1. Slow injection, so the pressure is not high. In case I do enter an artery, it will not go in a retrograde fashion. So, It's important to pay attention to the details. Now I have an arc going across. The indentation is resolved. We're going to stop at that. I'm going to continue laterally. I'm going to follow the zygoma, the lateral zygoma. I'm not trying to recreate another bone superior to that, or appearance of another structure which does not exist. You okay so far? I'm sorry if I'm hurting you. Thank you. Yeah, but please, I'm sorry I didn't take the one you were offering to me. I got that. No worries. One more. Now here, potential bruising, we make sure we keep pressure on that. I'm going to come laterally. I have not placed any fillers here, but it appears maybe there has been some fillers placed a little bit more superior. And that is 0.8. I'm going to pass that down to you, if I may. Now, quickly, I'm going to inject the other side, and we're done. Then off camera, I'm going to inject some Dysport, lateral canthal area, frown, let me see that. Corrugators, nasalis, and raise your eyebrows, ever so slightly lateral brow superiorly, and really not do much to the frontalis because I need that to be elevated. So far, you can see I got some more lateral projection to the cheeks, and I had evaluated the patient obviously before injection. Quickly, we're going to address the other side contourally. And some impregnation would be I don't need much lateral projection, but I need this to be improved. Orbitomailar fascia, sometimes it's very difficult to be raised, and if I place it without any improvement, I stop. Otherwise, I'm going to have the donut effect as a result of that. This is superficial. That's the only way I can raise that. In her case, I'm just putting small amounts and seeing how it responds. If I'm not getting what I want, I stop and change my depth and also the direction of placement. So compared to the other side, on a more superficial aspect, I can see improvements, then I'll continue. So far, I've used about 0.4. Now we get it there. More inferiorly. A lot of things I don't think about anymore, but I pick a point, perhaps where it's the most hollow, and then build around it and create a transition point. Here we are. Now we have a smoother arch, a little bit of a hollowness there. Forgive me if I'm hurting you. Thank you. And the reason I'm going to go back here, I'm more convinced that there must be some filler up here, but if I may turn you, that goes a little higher. Just want to make sure that transition a little smoother, very, very slight amount. I just feel like it is all of a sudden stopping and not transitioning back. So the amount as I'm going to place is maybe 0.2. There you are, Hardy. And that is it with our patient here. Off the camera, I'm going to inject the Dysport. Is that okay with you, Dr.?
Lighter version, okay, of the Bicross family. It has a concentration of 15 milligrams per ml. This has an FDA clearance for treatment of the tear trough, which has, some complex anatomy anytime we're doing something around the eye. So when we do this, I always like to use a cannula because we're going to be coming in the periorbital area and coming deep underneath the orbicularis muscle, and we're going to aim for the area of the infraorbital foramen and deposit a small amount of product there to help anesthetize the area. And whenever we're doing injections around the eye area, you have to go very slow and full ophthalmologic examination. And I've put in a little bit of local anesthetic where we're going to make a little entry point for our cannula. And we're going to be using a 25 gauge, 1.5" cannula here with the product. And one thing I will say, the hub of most of the Vicross products, they're kind of tight. And when you try and put on a cannula, you don't want to screw it on too tight because you can sometimes crack the hub. And it's just the thread spacing that we use when we're dealing with the Vicross products. So Volbella is kind of the lighter version of Volux, which is on the other extreme, which Dr. Murati is demonstrating. And then coming in the future is going to be an even lighter version of this product called Volite, which next year we'll be talking about. So I'm going to go ahead and prepare for the entry point for our cannula. And we're using to clean around the eyes because alcohol sometimes stings a little bit. We're using this product, which is hypochlorous acid, which is a natural antibacterial solution. Your body produces it naturally. And so it has like a slight smell to Clorox almost, but it's safe to use in the eye. Ophthalmologists use this product all the time for blepharitis. And so we're going to use that just to kind of prep the skin area. And so hypochlorous acid is a very helpful adjunct. And of course, Hibiclens can sting the eye, and alcohol is sometimes uncomfortable. So we do like to use our hypochlorous acid solution around the skin and the eye. Okay. So, we're going to just take a little poke here and just trace this through the skin. Just a little poke here. So we just use our 25 gauge needle just as an entry point, and you can see where I'm entering. Because we're going to be treating the tear trough, we want to be kind of in the mid-cheek, which gives us enough working distance to come all the way to the near medial canthal area, and also the ability to come laterally into the lateral orbit area. So you want to give yourself enough working distance to reach all the areas nicely. Okay, so that's our little pilot hole, and then I'm going to go ahead and place this one as well, so then we'll poke here. And I usually just leave the needle on the other side because the hardest part of the procedure is really getting the cannula through your insertion area. Okay. And we always want to prime your cannula before you start injecting, so you're not injecting air. There's a little bit of space there, so we're just going to prime that little area here, and we can see a little bit of product. And I always tell the patient whenever we're working around the eye that it's kind of a unusual feeling, and you always want to make sure the patient's head is stable, not moving. So we kind of discussed that you're going to feel a little tingle once we get this product close to your sensory nerve, and we're going to deposit a small aliquot of the filler, which also has some lidocaine inside. And then we'll be able to use small amounts. So the volume that we're typically going to use in this area is going to be no more than, say, 0.4 or 0.5 cc's in the area. So, just going to come into the so the hardest part is kind of pinching through, so I always like to kind of tent up the skin a little bit, and I tell the patient that you're going to feel a little pressure here, so 1, 2, and 3, just a little pop. And so we're going to palpate right where that infraorbital area is, and the patient can feel a little bit of tingle there. And I'm going to go ahead and just deposit just about 0.05 cc of product there, and I'm going to wait for a minute. And so in doing this, we'll give some chance for the anesthetic to further anesthetize the area. And then we want the patient to be able to open their eyes and look straight up and see here. So again, the anatomy that we went over earlier is where the orbitomalar ligament kind of comes across, and that is an area that we're going to traverse. And so we want to kind of deposit some of the filler on the superior and inferior aspect of this area just to lift up the tissue. So we're basically just down to the periosteum. We're going to be underneath the muscle with the product. And again, I'm going to palpate here a little bit. And now we're going to just administer small amounts here. Okay. How are you feeling there? Okay, good. So now we've kind of gone through that. So we're going to, again, you can see I'm trying to tent up the cannula. You can see that we're fairly deep and just kind of hugging the periosteum. And using a cannula in this area, if you inject slowly, there's going to be less risk of getting bruising, obviously. And I'm just going to feel here again.
again. And you can tell when you're down deep against the periosteum, they feel it a little bit more. And so we're going to go ahead and deposit again, just a small bit there. And then we're going to back up, create a little tunnel up here, small amounts here. And you're always kind of feeling where the tip of your cannula is. And then we're going to come back. And just right on the supraperiosteal area, just depositing just about 0.1. So these are like 0.1 cc aliquots along the area. And you can, because we're deep, you're not going to have any lumps or bumps. You're not going to see the Tyndall effect because we're underneath the orbicularis muscle. And again, less chance for bruising and whatnot. And then the patients will have numbness of their lower eyelid, so we'll just kind of explain that to you. And that typically lasts for about 30 minutes along the area. So the hardest part is also kind of giving a smooth transition from the medial aspect into this lateral part. And Dr. Moss showed very nicely about using the higher G' products to kind of lift up the face as well to kind of balance that area. We're going to come back through here, and I'm going to just like changing the direction here, we're going to kind of just 3 little fibers here, right at the lower ligament, and deposit again a little bit more. So far we've put in right about 0.4 cc's of product. And now we're going to just come right back around this area here, and just in the lateral aspect. And this one is a little sensitive, because it's not quite in our nerve block. This is the frontozygomatic nerve that comes out just through the maxilla dome. And I'm going to just deposit just the other 0.1 cc of product there, just to smoothen the transition here. So now we've got that all done there. So with just about a half cc of product, we basically smoothen that transition. You can open your eye now, straight up there. So you can see a little bit of the difference between the two sides here. And then we're just going to place a little bit of an ice pack over the area and come to the other side. So the key thing is that the injection is deep. A little bit of discomfort for the patient. And it works, very well. We're not injecting superficially where you get little nodules and bumps there. So that's the lobella from the tear trough area. You can kind of just lean forward here just a little bit and kind of see that in the camera, so you can appreciate the difference between the two sides with just about half a cc of volume in that area. Okay? I'll come over to the product. So rarely do I ever put more than 0.5 cc in each side. Let's say we have to remove the tear trough. And then I'll have the patient come back, usually after about 3 weeks, take a look at the area, and then we might just add a small amount if need be. So I'd rather let it rest than get a full correction, especially with the new patient with tear trough.
So we're going to look at my patient here. So our objective, you can just relax your face, was to make this contour from here to here straighter. This was a wider side. The angle of the mandible was more protruding on that side. On this, we place a small amount here, we brought the zygomal laterally. More importantly, I want you to pay attention to the angle of the mandible here. Now she has more of a structure there and a better projection laterally. I'm going to have you sit up just a little bit more. Perfect. And chin down a little bit, please. Perfect. Now you can see better symmetry, although you can only replace some. But the fact that we have more symmetry and the fact that we only use 1 cc of Volox to be able to accomplish that. Thank you. Thank you so much.
Thank you.
Dr. Moradi, the question is for the Volox. What plane were you in? Were you subcutaneous or were you periosteum?
So lateral is over the catheter and it becomes tissue. So it shouldn't be very superficial. As we come to a lateral zone, subcutaneous is also quite rich. You can go over the lateral to this state you can go in the mental zone, which is over basically what is close to the
Dr. Marty, do you want to speak to a little bit about how this filler feels a little different?
So when injection of filler requires a little bit more pressure, or that resistance, you get it better with the jaw. That's what we're doing.
Okay, so we're done here on the south end. Have you leaned forward or just everyone was going? Sit forward here just a little bit. That's good. That's perfect. So we just kind of finished treatment of the right side as well. And again, with this type of technique, there's just very little chance of bruising. There's going to still be a little bit of swelling, in the area. And the patients, we just tell them again not to drink alcohol afterwards, which is a vasodilator. And not to be alarmed if the first couple of days they have like a little bit more swelling underneath the area. But under eye tear trough fillers, we like using Volbella, we like using some of the Restylane products as well, things that don't gel to swell too much. The nice thing about Volbella is that it's a very low concentration of product, and again, because you're placing it deep, it works very well. The other indication is for that, for fine lines around the lips as well. So that's the product. Okay, very good. Thank you.
So, again, wonderful, beautiful young lady here that we are going to be injecting Volux. She's had prior fillers as well. She's had great, filler injection in her jawline in the past. But most importantly, there are two things that we have to think about is, once again, we have minor but some facial asymmetry with the laterals or of an angulated area. This is, you can see the jowling portion more prominent here, and you can't really see the angle of the mandible, of course, there. So our job is to drop the mandible. Start with the right side. May I? No, I will go with the injection. Thank you. We're going to turn you to the side a bit more. I'm sorry. You okay with that? I'm going to have you sit up a little bit more so you're not at all slant. Perfect. Look, there you are. You okay there? Mm-hmm. Excellent. So, palpation. And take on a notch. I'm going to turn you right there. So from here to here is masseter, medial fold, mental fold. And this is the buccal zone, and in this area is really subcutaneous tissue, fat, and bone. Now, are you ready? Palpating where her natural angular mandible is, which usually should line up with the axis of the ear. I want to project this inferiorly, give her an angle, and bring it laterally. If I go too deep, then it's going to take a lot of product, causes her to look doughy. First thing, I'm going to go inferior to the mandible. So actually, I'm sliding right over the inferior aspect of the masseter, retrograde placement. My first injection was 0.2. I'd like to stay 0.1. Again, this is less than 0.3. I'm already getting an angulation right there. You do not need a ton of product with Volvox. And this is the antigonial notch. You can actually see a little bit of outline of the facial vein coming through. So right here, antigonial notch. I'm going to go past it just a little bit. I don't want to add to any jowling. Now we're starting to get more of a straight structure. I'm massaging the area. Going back, I'm going to bring the ankle more posteriorly. Therefore, I'm a little bit above the angle of the mandible. Here, 1, 2. Now I'm going to bring it laterally. I have another Volvox ready just in case if we have one. Let's see where we stand before we go. I'm going to turn it. So, much more symmetrical. Now our attention is not going to the jowl area. It goes, now we have an angular mandible to look at from an AP view. And we have used 1 cc only. At that point, I was going to use another syringe, but I feel like that's unnecessary. I'm going to bring here more lateral with whatever I have left from my first cc. Thank you, be careful. So that was one side. The other side has to be done differently and does not need that much. I'm going to show this to you one more time. Look at the angle. Brought it posteriorly, laterally, and inferiorly. And turn it back. Oops. Thank you so much. I'm going to turn you to the side. You can see it's just blunted a little bit. So we're going to, I know she comes in more inferiorly, but her actual angle is here. So there is some fullness in the subcutaneous tissue. Again, I'm going to palpate axis of the ear. The angle looks as it's here, but it should be back here, and the bony landmark is here. So I'm going to accentuate her own bony structure. I'm deep over the masseter. That was 0.15 actually. I am approaching the antigonial notch right here, which I don't really need to spend much time there. Just a slight amount so that the hollowness does not show there. I'm going to go back. I didn't expect to place 1 cc, but as I'm placing it, it tells me where to go next. I like to bring laterally, the mandible laterally, so I'm over as close to the ramus as possible, which is really, I'm over in the subcutaneous tissue, but I'm not superficial. So you can see how you can make a product look good and how you could possibly make a product look bad. This is a great product, but it has to be presented and injected in the right plane and anatomically the right way for the individual. Now, we went from a face that was very lateral, now we can see the angle of the mandible. It gives it more balance here. That was 1 syringe per side. Thank you so much. You stay right here just in case there are any questions.
That's great. Do you have any questions? How far can you extend the appearance of the ankle comfortably?
How far where? Back, forth, laterally? Posteriorly. You do not want to pass the axis of the ear for women. Absolutely not. Men, you come to the axis of the ear, you can go a little posteriorly, but not for women. And axis of the ear, you can see is right there. And anatomically, if you look at, just pick some individuals on the magazines that are models, draw that line, take a look at it, where that line ends. That's where the angular mandible is. Men, you can go back posterior. Some are actually more posterior. Women should not be, just makes them too masculine. But, I'm sorry, I didn't hear you.
How deep are you at the genome and the groove?
You're talking about You're talking about the mandibular ligament placement? Is this what you're speaking of? Right here? Okay. So I didn't place any, but there are patients. Now I'm going to actually address that because that is a very, very difficult placement. And I wish I had a patient that, both my patients were perfect. But individuals who have hollowness here, and you're right, you create a groove after a while in that area. Now, those individuals, if you place it deep, it's going to cause a donut effect. It's going to come to either side. For them, you have to be subcutaneous and inferior. You notice if you look at him, there's some hollowing occurring right there. So you need to make sure you go in.
Which is also an HA that is also a 15 milligram per ml concentration. The other product we like using in this area as well is the Bellatero product because it has very little cross-linking. So you want to basically use a product that you can inject very superficially just into the actual dermis. And so that's what we're going to demonstrate. So we have a page, we can kind of zoom into we're going to just zoom into these little areas here. And this is a common concern that patients have. And oftentimes, we talked about using a little bit of neuromodulators as well. Maybe go ahead and kind of pucker for us here a little bit. So we can see these are not, smoker lines. It's just lines that occur because of the overuse of the orbicularis muscle and some thinning of the dermis and fatty tissue in this area. So this technique is one where we're going to be using like a little 32 gauge or 30 gauge needle. Again, this is a movie density version, so 15 milligram per ml. And so when we come in and we're doing this area, we're basically going to be doing a kind of a cross-hatching technique through the area. We just use some topical anesthetic here, and again, we're just going to kind of stretch up on the skin and primer needle again. And this one, because we're just sub-Q in the dermis, there's no major vasculature here, and this is a very forgiving product because you can massage it very easily, and because we're not into any major vascular areas, you can still have your patients drink a little bit of wine for superficial treatments if you're not going deep and touching the muscle and whatnot. So it's all about kind of getting everything done. So what we're doing is we're going to be laying down some little bars here of this product, and that's going to help numb up the area. We're going to be going on the vermilion part as well on the lower aspect. So you can see how thin the needle is there. We're just right in that subdermal space here, and the product will spread very easily. And so now that we have these very thin products, we can reuse them, like the way we used to inject the collagen products like Cosmoplast and Cosmoderm as well. And here we go again, just a little bit here, through there. And so once we've kind of laid this area down, then we're going to come and go from above to below, or you can go from below up, either way. And we're just going to go right into these little lines here. So the first part was just to kind of get them numb a little bit. And so redensity is very helpful to treat these fine line areas. We can also use Volbella in this area as well, like I said, the Bellatero. And patients don't have a tremendous amount of swelling because of the low concentration of the product, and so there's not much swelling afterwards. So just a nice type of product to use when you want to thicken up the dermis. Now, using PRP as well, some people will mix a little bit of PRP with the fillers as well, which is great. Doing micro needling is also helpful, in this area. And patients, depending on what their downtime is with the filler, it's just so easy because there's very little downtime with it. And of course, we'll combine this with other HA products if we're trying to treat more the marionette area or the nasolabial groove areas. So.
If you're going to treat her with neuromodulator, would you do it at the same sitting, or would you have her? Yeah,
that's a great question. So, typically
we'll go ahead and use some neuromodulator at the same setting. Typically, I will do the neuromodulator first, okay, just so that it's not dispersing more in the HA. We'll typically treat the couple units in the mentalis and just 1 or 2 units in the superior avicularis as well. So I'll go ahead and do it at the same time. Usually it's not a problem. So we'll continue on here. And then we're almost to the end of our demonstration. There's going to be some lip filler being demonstrated with the Versa product. I think that's what we're teeing up next. And Dr. Murati has graciously allowed us to post 3 wonderful training videos with the use of the Volux that you just saw demonstrated. And they will be up on the website by the end of next week. So lots of information to look at. Okay, any other questions? But we're just kind of finishing up here. And it's like laying down rebar here a little bit, both vertical as well as a crisscross pattern for the patient. And then we can come and highlight a little bit of the vermilion now that you've been known through here. So I do like to place some of this product in the white roll of the lip as well, because those lines come down into the pink portion of the lip. And it just serves like a little barrier so you don't get the lipstick bleed into the areas, right? Okay, we come over on the other side and finish the area.
How do you know for this? Do you only use topical or do you do any nose swab?
I'm sorry, what was the question?
How do you numb when you treat this area? Do you only use topical or do you ever do nerve blocks?
Yeah, so in this case, we just use topical because Deb's pretty tough. But, if you just start off slow and put a few little aliquots in the quadrant, let the lidocaine sit, maybe come back and see another patient, you'll get a nice little field effect. But we don't hesitate doing a nerve block for patients just because it is a very sensitive area. Just hydrating the tissues up very nicely. And you can see, Debbie here, she's pretty tough. She's not flinching at all with just the topical. So you can go ahead and go to camera number 2, and we have Nurse D, who's going to be demonstrating some lip augmentation for patients who want a little bit more volume. And so Dee, tell us a little bit about which product you're going to be using and how you prepare the patient.
Yes, let me turn on the mic. Hello everybody, my name is Dee. I have this beautiful patient. She is Jenny. I just want to say an anecdote. She put me all patched. She is the rep of LifeWave, so I'm patched. She called me the patch lady. Anyway, so this is a side joke. Okay, so Jenny has very nice lips, but with age, she has lost some volume around the mouth. So our goal today is to revolumize the lips. She wants really natural looking, so it's we are going to rehydrate the lower lip and then give some height to the upper lip, just a little bit, just to give her some nice plump lip. Also, if we have time, we're going to do some revolumizing around the mouth. She has some volume loss. Yeah, so I'm going to use Revenus lips. I like Revenus lips because, first of all, it's a syringe that has 1.2 ml, which is a great volume. It's a generous syringe. Also, I like the physical characteristic of the hyaluronic acid is a gel that is really, when we inject it, it is very forgiving, so there is no lump or bumps after that, and it's very soft, and we can use it on the lip. It has low risk of, swelling. It's not very hydrophilic because it is pre-hydrated. The processing of Revenus lips is already, in the manufacturing, it's already hydrated. So let's see, Jamie's lips is pretty symmetric. So when we assess the lips, we look at the border of the lips. So we need to give you some crisp border. So we're gonna fill the border because you do have some smoker lines. So we're gonna rehydrate the upper and the lower and revolumize the upper. I start usually with the lower, it's less painful. With lower lip. She does have a banana, I call it the banana lower lip, so we need to give her some volume on the tubercle on both side and the bottom, so we'll give you some Angelina Jolie, lower lip. And then the upper lip, we're gonna try the tenting technique, or I can call it the chicken leg technique, so we can give it some height. So let's get started now. What is unique about also the Revenus lips that they have a 30 gauge needle that is very particular. It is manufactured in Japan, and it is, although it is a 30 gauge, but the inside the gauge is bigger, so it's easy to push the product. One more thing is because the molecule, so the hyaluronic acid is a kind of a bead in a bead form, so it is easy to when we do the retraction. So when we check if we are in a vein or in an artery, it is easy to check. So it's not viscous. It doesn't stick to the syringe. Okay. So when I mark the lips, I don't like to add volume beyond the two extremities here. So we're gonna stay in these limits. So I'm gonna first of all start with the lower. And I'm gonna clean with alcohol or hypochlorous acid. She does have some lipstick. Oh, Chanel. She said Chanel lipstick. It doesn't. It's stained. So let's remove this. So I'm gonna prime my needle, and then I'm gonna go on the border, and there is a trick. So on the lower, so on the border, if you are, I call it on the tube, there is less risk of migration. So the trick is if we see a kind of a tunneling, it means we are in the right plane. Also, like a reminder of lip anatomy. So the lip is vascularized by upper and lower. So upper and lower, and I forgot. Sorry. Just. So the upper and lower labial artery, sorry, because she was in pain, I was distracted. So the upper and lower labial artery that originate from the facial artery. So the plane of injection has to be subcutaneous because when they look at the variation of anatomy, so most of the artery, the upper labial artery is behind the muscle, but also it can be like 30% can be inside the muscle, so we have to be away from the dry, wet border. So how do you know you are on the right plane? You have to, when you inject, you have to see the needle a little bit white, so you know that it is in the right plane. If you cannot see the needle, then you are in the wrong plane. Doing okay? Mm-hmm. Some people do a retrograde injection, some do an antegrade injection. I like the retrograde, but people who are a big fan of antegrade injection, they say they will numb while pushing the lip, so it's less painful. So. And Jenny wants kissable lips. So Valentine is coming on the 14th, so you are gonna be ready. Okay. I'm gonna change the needle because it's a little bit dull. And we have always 2 needles in So it's very important to ask the patient if they have history of cold sores, because injecting the lips can trigger an outbreak of cold sore. So this is part of the questionnaire. Some also, they get, this syringe has some lidocaine. Some people have sensitivity to lidocaine and they can swell. So we give you some border. So now we are gonna plump those tubercle. And when I inject perpendicular, I stay at least 1 to 2 millimeters from the wet, dry border, because sometimes there is vessels there. So let me go on the other side.
Her main concerns are her lower facial area and the perioral and marionette lines. And I showed this a little bit earlier. one is Bellatero again. And we did a study and we looked at Restylane Silk, and the Restylane Silk was not quite as smooth, but there were tiny little bumps, but it was, but it lasted a little longer, and neither of them, as long as they were less than 10 milligrams per milliliter, gave it any kind of Tyndall effect. And you can see the little crack at the corner here, so my goal is to not have any extrusion, but you're going to get a little bit if you're very superficial, just like you would if you were doing collagen. For the people that are old enough to remember collagen product. And I lifted that, so now our mouth looks straight, but I'll do all these little fine lines. It takes time to do it, and so I think this is a good thing to train your nurses to do and delegate it. I mean, if they're patient and willing to learn, they can do a nice job of lifting these little fine lines up and lifting what we affectionately refer to as a marionette line up too. And this is so this would be Bellatero comes 22.5 milligrams per mil, so you'd have to put about 2.2 or so ml of lidocaine in. And then we mix it back and forth. The tulip makes a little connector syringe that tapers in the middle, so it creates a little more turbulence and does a little better job of mixing than those red ones that they send from nurse for mixing lidocaine in with the if you do dilute radius, which is a nice way to deliver the radius, so the particles are not so close together. And so we have made some progress on the two sides if we compare them. That's sort of a deep line over here, almost like a Y, and then I'm going to come back over here, and certainly much less. So we can maybe get a little bit more and do a little bit of these lines. Again, this feels to me like it could be mixed a little better. Sometimes if it hadn't been mixed in a while, they will separate back out and you get a little too much of the lidocaine and not enough of the HA or vice versa. So when you do it, you really don't want to let it sit. And this might have been sitting for a while. So that goes for now. So whoever's mixing it should be mixing some more, but right now I don't know who's doing that. We got to stand in now. So, and then she's got, first she goes over, you're going to listen. So she's got very deep perioral lines, and on the upper lip in particular. I'm going to bring this up just a little bit. And I always start at the top when we're doing this. The best treatment for this, I've said this before, is, and I'm making, is to do laser skin resurfacing, or a deep chemical peel, or even dermabrasion, whatever your flavor of resurfacing is. I don't think many people do dermabrasion anymore, but it certainly works well if you know how to do it, as to deep chemical peels. But all of us have lasers now, so we think most of us are using that. Fractional laser certainly has shorter recovery periods, and that's a big deal for a lot of people. But that was a deep line a few seconds ago, and is now not a deep line anymore.
We have a question, Dr. Moss. Why would you choose Bellatero over another filler in this area, such as Refine or Redensity?
We do Redensity, RHA1, 2. I can't actually don't do the mixing up of the stuff, but we tried them all just straight, and Redensity I think is 12.5 milligrams per mil. I think that's right. But I know it's small. It's less than Glabella, which is 15.5. And even at 15.5, you get a little bit of Tyndall, and you can see a little bit of a ridge. Bellatero seems to be the least amount of Tyndall, so you can have a little more wiggle room, but I don't think it probably matters that much. I do, I told you about our study where we compared inside a split lip study, which is published now, but with Restylane Silk. And Restylane Silk is, I would just say, very hydrophilic, so that might be a benefit here in some ways, but you still want to avoid that, what I call the, monkey lip or mono lip, where you really puff the lip out, because the goal here is to put the least amount of filler just in the lines, and don't puff the lip out so that it's, looks obvious, which is pretty commonly seen. I may see it on TV, I see it on, just parties and things. So the idea is to keep it in the lines, and any of those would work well. RHA1 works well. We haven't studied which is redensify. Although I can't say we haven't studied any of those. If you were doing those are worthwhile split lip studies. But this is time consuming. So we charge by the area, and your time is what's valuable. So if it takes a half an hour to do a lip, then that would be a lips major or intermediate, depending on how much volume you use. But we remind the patients if they ask, which they really don't often ask, but that we're paying for the service, not for the product. So, like if they ask me how many, common term is how many tubes do you use? And I remember how much it takes to make it look good. But if you start at the top here, you see she's got a little discomfort. This is where the sensory nerve supply comes from. And if you get that area done, then the rest is much less painful, much more comfortable for the patient. It does make your eyes water to do this. I've seen it. It's more of a reflex, but it stings. And with someone like this patient who has blunting of the junction of the white and red lip, that she would really benefit also from doing a little border augmentation with one of the fillers that are not too hydrophilic, like Resty, Kiss, or Vobella. Vobella is really nicely saturated. I haven't done a ton of the RHA 3 or 4, but we've done a fair amount of the Densify for fine lines. And like it performs well. Teoxane is the number two product in Europe, so it's already established itself as a solid player in the world market. And usually there's reasons for that: performance, characteristics, duration. All these things that we, they're subtle, but they're important. So I'm going to go over this side of the other side. So we get this line, and it's serial puncture technique, so I don't have to chase the line up. I'm really coming in at an angle and just lifting the line itself up, and I'm really trying to stay just intradermal. Pressure, just kind of go back and forth between. And then they'll reduce the nurses when they're diluting this or blending it, as they like to euphemism. Then they make sure that they've done it enough so that there's really a nice homogeneous thing. You don't want to have some filler and then some squirts of the HA filler coming out. And I can tell when it's not done well, because it gets a little harder and a little easier to inject it. And that doesn't do well for the patients either. So that looks good. And then before we finish, I'll come back to this other side. But you see the principle of this. It's intradermal. It's not making her whole lip fat. It's reliving the old days when, although collagen was a far for this application, collagen performed magnificently because it was it basically worked as a hemostatic agent, barely saw any bruising, which is why I use these lidocaine with epi when I do this, so that it gets a little vasoconstriction. Because you get little dot bruises when you do this. Right in both ones. Oh, and the patient is asking a question, and I do it right in the lip lines. I would, if you're doing that, you better just plump the lip up a little bit. Because the lip, those are not really, those lip lines are not, have nothing to do really with attractiveness. Some people really have lots of quality and they have nice full lips, and that's still an attractive lip. But if there's plumpness or really definition of the border of this patient, that's an option, which we can do a little bit later too. Yes. Okay. That was about Terry when we get me some rescue kiss or. Any questions about that? Or are you going to move over back to, Nurse D's still working away over there on something?
There is something missing. So we have to treat around the lips to support the lips. So I treated one side and we can see the difference. I use a cannula around the mouth. It's safer, faster, and easier. And less bruising and also less pain. So we augment the lips, her lips. So we hydrated the lower, like the plan we talked about, and then we gave her some height. On the upper lip, we redefined the Cupid's bow. We supported. She did have inverted smile, kind of the corner of the lips were orienting downwards, so we lifted it a little bit, and then we add some volume around the mouth, the oral commissures, the little bit on the nasolabial fold, the upper lip, and then also under the menton. So usually we get a better result when we treat the area as a whole, not just the lips. So, and then we need to ask the patient so the post-care is very important. So don't massage, or if there is any pain, they need to call us. The swelling is gonna last for a couple days. I usually advise to use some arnica or ice to help with the swelling. That's it. So I'm gonna finish the other side so we see the improvement. Let me see, can you put the camera a little bit low so we can check? Can you? Yeah. So this is where there is the needle, it's not treated. I treated only the lower part, but we added some volume here. So it's gonna take couple of days to the hyaluronic acid to incorporate with the tissue and give her some volume.
Again, I'm trying to do it integrated, and if I can get that little lip rolled up, it'll make a huge difference for her. And I'll actually pinch along the lip over just a little bit and make sure it's right at the border. If you want more volume to the lip, of course, you might even use a different product that's more like a filler, but in someone like this, this is really a lot of actinic cheilitis that she's doing.
So that developed at her own, and so now you see kind of a wider products that we use from Quantum, and we definitely superficial dermis, and we get blanching. This product spreads very nicely into the tissue, and contains light area as well, so it's comfortable. So, fantastic. Any other questions in the audience? Okay, we've got true students here. Okay, so how many people here for fine lines of the upper lip use one of the products we just talked about?
Belotero, density, or Gold Belt. Okay, very good. Very good. Very good. Okay. Okay, well, when you fill out your evaluations, tell us a little bit about, what we're doing well, what things we'd like to see differently, and we're always constantly trying to improve, but we're able to kind of maintain things on time. So I want to thank Dr. Sunder, Dr. Morass, who are going to take off, and of course Dr. Moss and Nurse G back there. And we have an action-packed panel tomorrow on our outdoor plastic section, as well as some other interesting lectures. So looks like the snow is on the way, so you'll have easy driving back. And
we'll be skiing.
Place to go on the Super Bowl. So I'm going to take Kansas City. Who's going to take Philadelphia? Okay, we got one for Philly. Dr. Moss, who are you going to pick for the Super Bowl tomorrow?
I'm going to be skiing tomorrow.
You're going to be skiing tomorrow? Okay.
Yeah, my team is already out.
Okay, all right. Well, very good. Okay, well.
I think the Eagles are giving them a good run for their money.
Well, there's a sports bar downstairs. If you want to place a bet, you can do that. But I hope in Kansas City kind of pulls it out in the Midwest. Okay, that concludes everything. Thank you, guys. Thank you, guys.
Fill me up.
Looks good. I mean, change this ratio. I mean, it's good.